Assalamu alaikum. Hello, everybody. Thank you for joining. I hope everybody is in good health. As we all know that COVID-19 pandemic has pushed us to have this conference virtual. So we hope that we will get you all the information required and that you will enjoy the session. As we all know that antimicrobial resistance is a natural biological unstoppable phenomenon, which is driven by a rampant misuse of antimicrobial agents. We do know that 50% of antibiotics are prescribed inappropriately, 50% of patients have poor compliance to antibiotic, and 50% of the population do not have access to essential antibiotics. Also, 50% of antibiotics are used for growth promotion in some countries. Resistance has very huge negative impact on health, with longer duration of illness, longer treatment, higher mortality, more expensive drugs are used, and increases the burden on the healthcare system. This also interferes with the advances in the medical sector for complex surgeries and transplantation and other interventions. Patients also may act as reservoir for organisms which are passed then to the community and the healthcare worker. So all of this constitutes a huge economic impact on the individual and on the society. There is no time really to wait, and failure to address this will lead to 50 million deaths by 2050. COVID-19 pandemic has also added extra burden to the antimicrobial resistance, as antimicrobial has pushed many misuse of this, has pushed us to misuse antimicrobials in the view of the seriousness of these COVID-19 patients. Today in our conference, we will try to address COVID-19 related topics and its effects on antimicrobial resistance and infection control. So let's start our conference.
Give me a great pleasure to introduce our second speaker, Professor Jens Thomsen. He is a consultant clinical microbiology, and he is the chair of the UAE National Subcommittee for Antimicrobial Resistance Surveillance. He is the section head of the environmental health in the Occupational and the Environmental Health Department, Abu Dhabi Public Health Center. Professor Jens today will give us an AMR surveillance in the UAE. So thank you very much. The floor is yours, Professor Jens.
Thank you very much for the kind introduction. And I hope you can all hear me clearly, and also the screen resolution seems to be better now. I think the slides were a bit blurry before. So thank you very much for inviting me to present at this conference, and I hope you can see my screen here in front of me, of you, the presentation slides. So my presentation is going to be about celebrating 10 years of AMR surveillance in the United Arab Emirates. And the learning objectives are to describe the objectives of surveillance of antimicrobial resistance, to describe the current status of the AMR surveillance system in the UAE, and to describe selected patterns and trends of antimicrobial resistance in the UAE. So why are we doing AMR surveillance? The objectives of AMR surveillance, and why are we doing it? AMR surveillance is actually the key needed to track changing populations of microbial pathogens. We can use it to quantify the toll of resistance on human health. The data can be used to inform therapy recommendations or standard treatment guidelines. We can document risk factors for emergence and spread of resistance, including animal husbandry and food production practices. It can be used to guide policy and resistance containment interventions. Also to evaluate the success of public health interventions, to energize political commitment and resources to containment efforts, and to assess and guide continuous quality improvement and stewardship in diagnostic services. So AMR surveillance is very important, and there's many reasons to do it on a national level as well as on a local level or even on a global level. So AMR surveillance fits right in the middle between the clinical management of patients, the microbiology lab, and public health and epidemiology. In the UAE, we have a higher AMR committee, and under that higher AMR committee, there are several subcommittees. One of them is on AMR surveillance. And this is the subcommittee that is charged with leading and overseeing all the efforts in the United Arab Emirates on national AMR surveillance strategies and activities. So basically we are collecting the data, we are analyzing the data, we are reporting the data, even to the World Health Organization, and we report to the higher committee of AMR in the UAE. Following the WHO GLASS Global AMR Surveillance System guideline, for any national AMR surveillance system, there should be at least these three components. Number one, surveillance sites. These are the hospitals and clinics where the data is generated, where microbiology labs are generating microbiology data, but also clinical and hospital data. Number two, a national coordinating center, which is reporting to the national body of in charge of strategies to contain AMR. I'm just putting the laser pointer here. And also number three, a national reference lab, or NRL, for AMR. The current status of the UAE National AMR Surveillance System in the year 2020 looks as this slide shows here. So we have in all the 7 Emirates, we have a lot of small clinics or larger hospitals. In total, 250 surveillance sites, including 79 hospitals and 171 clinics, and also 38 microbiology labs, generating data and submitting to the concerned health authorities. And the data is then compiled at the National Coordinating Center, which is the UAE subcommittee for AMR surveillance as an interim. In the UAE, we don't have yet a national reference lab established. In terms of geography and location, in all the Emirates, as I said, we do have hospitals and clinics participating in the system, in together 250 sites and 38 labs, actually, not 34. There's a focus on the big cities like Abu Dhabi, Al Ain, and Dubai, but basically from west to east, from north to south, we have surveillance sites contributing to the database. So we could say that the data is quite representative for the UAE in terms of geographic location. Over 10 years, we are doing this since 2010. Over 10 years, we have increasingly receiving data from these facilities. It started in 2010 with just 6 hospitals and 23,000 isolates. And as you can see here, in the year 2019, we have more than 200,000 isolates reported and 75 hospitals reporting in the last year. Altogether, there's almost 1 million of isolates now in the database that we could analyze and report on. So this is quite a success story, I would say. With all this data we have, we are actually not using all of it. We are removing and excluding certain data, which is, for example, copy strains and multiple isolates. We only use the first isolate from each patient. We don't analyze screening isolates. We remove isolates from nose, axilla, groin as suspected screening isolates, and we remove internal and external quality control isolates to just keep and analyze diagnostic non-duplicate isolates, which are basically representing patients then, and not more isolates only. So these 600,000 isolates in total we can analyze, and we can do cumulative antibiograms on gram-negative bacteria, gram-positive bacteria, Candida, tuberculosis. We can do annual trends over time, and we can do breakdowns or enhanced antibiograms by organism, by specimen type or source, by location type, by age group, by region, by emirate, and so on. For the data analysis, we use a software called WHONET, which is a WHO-endorsed software specialized for conducting AMR surveillance, which we use and recommend for such purposes, even on a local or hospital level. In a nutshell, this is a summary of the key resistance rates in the UAE in 2019. So we can, for example, see that in Enterobacteriaceae, we have an ESBL rate of about 28%. We have Staph aureus and MRSA rate of about 35%. And we have penicillin resistance in strep pneumo of about 3%, and so on. Or vancomycin resistant Enterococcus faecium, 10%. So this gives kind of a high level overview on the most important AMR resistance rates. We also do a more detailed analysis called a cumulative antibiogram. So this here is on gram-positive bacteria for the UAE for 2019, % susceptible isolates. And of course, we don't have the time to discuss all these numbers here. So I will just highlight a few important points. For example, in terms of gram-positive organisms, Staphylococcus aureus, what we see is an increase of MRSA. Percent MRSA in all patients has increased since 2010 from about 23% to now about 35%. And this is based on 83,000 patients and 79 hospitals. This is a 10-year trend. So it's clearly showing that the MRSA is increasing. Now it's kind of slowing down the increase, but still increasing. And not only oxacillin resistance is increasing in Staphylococcus aureus, also all the other important classes like the fluoroquinolones, levofloxacin, moxifloxacin are increasing. Clindamycin, erythromycin, see here, for example, clindamycin, how it increased from, there was no resistance to clindamycin back in 2010. Now we have 14% resistance. Erythromycin increased from about 15% to 28% and so on. So we see that most other antimicrobial classes in Staph aureus have been increasing at the same time. If we do a breakdown by outpatient versus inpatient, we see this is true for the community-acquired MRSA as well as for the hospital-acquired MRSA. Obviously, the resistance is a bit higher in the inpatients, so about 40% here, even 43% in ICU patients. That is the current MRSA level of ICU patients. And for outpatients, we have about 30.4% MRSA now in Abu Dhabi, well, in the UAE actually. Another gram-positive organism are the enterococci, and we see here the trend of vancomycin-resistant Enterococcus species, VRE, which you can see is relatively low. So it was always below 3%. The highest was 2.9% here in 2015. And we can see that after 2015, it seems to be decreasing even. So this is good news. It's getting down, not up. In terms of different enterococci, fecalis is actually very susceptible for vancomycin, 0.6% resistance only, whereas Enterococcus faecium, the more resistant Enterococcus species, is 10% VRE. For another gram-positive organism, we found an interesting trend as well, which is group B streptococci or Streptococcus agalactiae, where we see an increase of resistance to macrolides and lincosamides. So we see clindamycin and erythromycin increasing. Clindamycin here on the left side from 5% in 2010 to now 30% increase. And even more, erythromycin has increased from only 10% in 2010 to now 52%. So we can say half of all group B streptococci are now resistant to macrolides or erythromycin. And this has implications on the intrapartum chemoprophylaxis of pregnant women with GBS who are allergic to beta-lactams. So it used to be 10% and now it's 50% resistance here, which is of course a concern. In gram-negative bacteria, we also do a detailed cumulative antibiogram, and just highlighting on some important trends here, for example, Enterobacteriaceae resistance to cephalosporins. We see that the second and third and fourth generation cephalosporins, represented here by cefuroxime, ceftriaxone, and cefepime, are all increasing in resistance, with no exception, even ceftazidime here, but on a different level. So of course, the second generation are more resistant than the third generation, and the fourth generation are still the best. But we can see ceftriaxone, which kind of represents the ESBL. We have about 27% ESBL now based on ceftriaxone resistance. And we can clearly say that resistance to cephalosporins and Enterobacteriaceae, and especially ESBLs, are increasing in the UAE. In terms of carbapenem-resistant Enterobacteriaceae, or CRE, we see here all on the right side, all Enterobacteriaceae resistant to meropenem, which would be percent CRE. Almost 300,000 isolates, and we can see it was almost not present back in 2010, only 0.3%. Then it increased to a maximum of 2.9% in 2016, and it goes down to 1.9% now in 2019, which is good news. So out of all of these Enterobacteriaceae, the one organism that is mostly resistant to carbapenems is Klebsiella pneumoniae. So meropenem here, we see it reached up to almost 9%. and now it's 4%. So the trend has been very concerning in the beginning, in the first 5 years. But since the last 5 years, we see a decreasing trend again, which is very promising and perhaps an expression of successful antibiotic stewardship activities. From other studies, we know from Professor Thibaut Pahl's study here that these carbapenem resistance genes are mostly OXA48, 41%, and 32% are NDM resistance genes. Another interesting fact that we found is that, that gram-negative bloodstream infections actually are showing an increased risk of death depending on the number of classes of antimicrobials non-susceptible. So this is Abu Dhabi Emirate data, and we see that, for example, every year we have about 285 on average deaths from bloodstream infections. And if the causative organism was very susceptible, then it was only 14% resistance, 40% risk of death. But if it was fully resistant, then there was a 70% chance of death or case fatality rate. So you can see if it's multi-drug resistant, 29% risk of death. If it's XDR or extensively drug resistant, 43%. And for the fully resistant gram-negatives, there's a chance of 70% of death. So mortality is increased in patients with gram-negative bloodstream infections depending on the level of multi-drug resistance involved. Pseudomonas aeruginosa shows a quite horizontal approach here. So multi-drug resistance is kind of going up and down between 20 and 26%. But we don't see a clearly up or downwards trend here. Coming to fungi, this is the last part here for the presentation. We do a cumulative antibiogram on Candida species, and we see, for example, that fluconazole susceptibility in Candida is 93%, so it's still quite susceptible. But the emerging Candida auris is actually concerning trend. It's a multi-drug resistant yeast, and we have seen a recent increase here. So just a little excursion. There will be a more detailed presentation on Candida auris later on today. But it's a very concerning organism, and it's globally emerging. We see it in the UAE emerging. It's difficult to identify with standard lab methods. It's frequently resistant to fluconazole. It causes serious invasive infections, and it is associated with a high case fatality rate of about 30% for invasive infections. And very interestingly, it can survive for a long time on surfaces, and it is resistant to quaternary ammonium compounds, or QACs, which are often used in hospital disinfectants. And perhaps that is one of the reasons why it can spread easily in hospitals and nursing homes and has caused outbreaks. So we saw only 1 or 0 cases in the past 10 years, but then in 2018, there were 9 cases reported, and last year already 92, which is a steep increase here. And interestingly, it affects mostly the elderly. So this is a breakdown by age group. We see that the median age for Candida auris is about 72 years, which is very different from all Candida species, which occur mostly in newborns or here in the middle, or then also in the higher age. And also it's a quite fatal disease. So out of 14 cases for which we know the outcome, 8 patients died. So the estimated case fatality rate is 57%, and it caused at least 8 deaths in the last year in Abu Dhabi Emirate. And this is the resistance rate here. Fluconazole, 72.5% resistant. Ampho B, even more resistant, but caspofungin and micafungin are still very susceptible. And coming to the end, so this is kind of a summary slide where we can see the trends for gram-negative bacteria. What are the worrying trends and worrying organisms are Klebsiella pneumoniae with increasing resistance in all these classes here. Carbapenem, cephalosporins, fluoroquinolones, aminoglycosides, cotrimoxazole, and multi-drug resistance. And for E. coli, also we see some increasing resistance trends for cephalosporins, carbapenems, and fluoroquinolones. But others like Acinetobacter, which I have not shown today, are showing very promising and positive decreasing trends. For the gram-positive bacteria, the most concerning organism is Staphylococcus aureus, where we have seen the increase in oxacillin beta-lactam resistance. And also all the other important classes are very increasing, except for glycopeptides, which are not resistant. We are reporting this data in several reports, and if you would like to see one of these reports, except for the middle one, which is still a draft, then please contact me after the presentation. I'm happy to guide you and share with you these reports. In summary and conclusions, AMR is not only a global but also a national UAE threat to public health. The UAE have established a national AMR surveillance program. We have a lot of surveillance sites in the system and labs. We have high quality AMR surveillance data, which are representative for the UAE. And we have findings that some AMR priority pathogens, the resistance is high or increasing in the UAE. The pathogens of greatest concern are Staphylococcus aureus, Klebsiella pneumoniae, and Candida auris. And the antibiotics of greatest concern are beta-lactams, including cephalosporins and carbapenems, and fluoroquinolones and macrolides and lincosamides, for which we see a lot of increasing resistance. The resistance levels vary between emirates and facilities, which I have not shown today, but we have the data to show that. The resistance levels also increase from outpatients to inpatients to ICU, which I have also not shown today. Multi-drug resistance, MDR, is a risk factor for mortality for patients with gram-negative bloodstream infections in Abu Dhabi. And I would like to give thanks and credits to all many other people involved in these studies, especially microbiologists, pathologists, lab technologists, focal points, and IT experts, and of course the UAE subcommittee for AMR surveillance. And these are some references here that I have used, and I would like to thank you for your interest in this presentation. And if you have any questions, comments, or concerns, please feel free to email me at the email address shown below. Thank you very much.
Thank you very much, Dr. Jens, for this great presentation. You always give us new data about what's happening in UAE with regard to drug-resistant antimicrobial organisms. I would like to introduce Dr. Bassim Zayed from WHO. He's an expert in antimicrobial resistance and infection prevention and control. He's working with WHO Eastern Mediterranean Region Office in Cairo. Today, he will be speaking to us about infection prevention and control in the context of COVID-19.
Good afternoon, colleagues, and it's a pleasure to be part of this interesting international conference on antimicrobial resistance. Thank you, Dr. Najiba, for the introduction. Today, I will be talking to you about infection prevention control measures in the context of COVID-19. Will try my best in the few slides to cover the IPC core components and minimum requirements at national and healthcare facility levels. We'll be talking a little bit about specific IPC measures in the context of COVID-19 and elsewhere. And if time allows, we'll talk also about the healthcare workers' protection during taking care of COVID-19 patients. As we know, this is a new pandemic which have started with this year, and now 10 months into this pandemic, we are still learning a lot. The available data, although has some limitations, of course, indicate that COVID-19 infections among healthcare workers are somehow greater than the prevalence among the general population, although healthcare workers represents in most of the countries around 30% of the population, and in some low middle income countries less than that as well. Yet we see that 14% of reported cases of COVID-19 to WHO, for example, are among healthcare workers, and these prevalence is even higher. This proportion is even higher in some countries, reaching up to 35%. Of course, we have data issues in terms of quality and completeness, and it's not possible at this stage to differentiate whether most of these infections to healthcare workers happening in their healthcare facilities because of contact to suspected / confirmed cases of COVID, or they got infection in the community. We have many countries where we have community-wide transmission and healthcare workers being part of the community that might be also exposed. So it's difficult at this stage to differentiate and they quantify which proportion of those infections among healthcare workers are in the workplace and which are in the community. From the literature review, what's available is in healthcare settings, certain exposures, example, those particularly those associated with aerosol generating procedures, particularly intubation, extubation, um, medical interventions with direct patient contact, contact with body secretions are associated with the increased risk of COVID-19 infections among healthcare workers. So far, data indicates that there is no association between age, gender, or healthcare worker, particular job, or particular specialization and risk of SARS-CoV. SARS-CoV infection observed in various hospital departments without even direct patient contact. And on the other hand, appropriate use of personal protective equipments and hand hygiene have been found to be associated with decreased risk of coronavirus infection among healthcare workers. And also universal masking, which WHO is now promoting in healthcare facilities for healthcare workers, particularly in areas where we have community-wide transmission. This also has been associated with decreased risk. And of course, training of healthcare workers on IBC measures also is associated with decreased risk. So I think the important message today is 10 months through the pandemic, it has been clear that infection prevention control is important factor, is a key element to combat this pandemic and also to protect healthcare workers. Whether this does at the national level and the healthcare facility level, by staff or by senior management, it's very important, and it expands even beyond the healthcare facility to cover also measures in the community. We have been talking about IBC measures in schools, in public buildings, and in workspaces, and so forth. Why IBC is important? I think I don't need to confirm that, but I think we agree that this is very essential, particularly in healthcare facilities, to protect and prevent harm to patients, healthcare workers, and visitors. That's why WHO has been working with global experts and countries and has developed an evidence-based core components for effective IBC program document. These are 8 core components at the facility level and 6 core components at the national level. These are evidence-based recommendations with some good practice statements who are supported by evidence from literature, even including evidence from low middle income countries. We have developed many implementation guidance and communication toolkits to promote these core components. And I think time has proved that these are very important in countries and healthcare facilities where they have started to achieve those core components. We see lower rates of infections in those healthcare facilities. But we have been working further with, particularly with low middle income countries, on minimum requirements. These are the first steps of building the national and healthcare facility core component system to achieve the actual core component. And I don't have time to go into each of the core components, but very quickly at the national level, as we said, we have 6 core components. IBC program, there should be a national program at the national level, at least 1 full-time trained IBC focal point and a dedicated IBC budget. There should be a national guidelines, which is evidence-based, covered most of the IBC issues. There should be a national plan for training and education of healthcare workers, and also the IBC practitioners in the country. And there should be a surveillance system to monitor trends in healthcare associated infections and antimicrobial resistance. And thanks to my colleague, Dr. Jens, he's been talking excellently about the AMR surveillance system in Emirates. All of these, of the previous 4 important components, they should work together. We should tackle the issue in an integrated way, in a comprehensive way, into what we call the multimodal strategies to focus or to act on more than one of the core component together to get better and synergy effect. And of course, at the end, to monitor and audit and feedback the practices and principles to healthcare facilities and to staff. In addition to the 6 core components at the national level, we have also 6 core components at the facility level, but in addition, we have additional 2 specific to healthcare facilities. These are the workload and the staffing. We should have good staffing level, patient to staff ratio, and also we should have avoid overcrowding in the healthcare facility, establish triaging system, appropriate patient flow system, so that we decrease opportunities of contact and transmission between patients, visitors, and healthcare workers. And lastly, the last core component is to have a good infrastructure for infection prevention control, available supplies, available infrastructure for wash, for the water, sanitation, and hygiene, appropriate supplies of personal protective equipment, appropriate single isolation rooms or areas where we can cohort a patient together. And all of these have been proven to be very effective during response to COVID-19. Now let me talk specifically about the IBC measures that WHO is promoting to limit the spread of COVID-19 in healthcare facilities. Before talking about that, let me just quickly introduce to you a very important topic in infection prevention control, which is chain of transmission. This is and it's true also in the community also is how microorganisms transmit in both healthcare facilities and the communities. We have the organism which is present in a reservoir or a patient, for example, in a healthcare facility, and through places of exit, it can exit the reservoir of the patient, and with a particular mode of transmission, it starts to move from the reservoir of the patient to the next susceptible person through a place of entry. And this is how the chain of transmission continue, and this is how new persons get infected from other reservoirs or patients. And our role in healthcare facility actually to break this cycle, to break this chain at every possible opportunity, and this is how we do to stop transmission of infection in healthcare facilities, and as I said, also in the community. For COVID-19, the modes of transmission of COVID-19, the known transmission, the primary one is through droplet, through respiratory droplets that generated during coughs and sneeze and sometimes talking loudly. This is the primary mode known of transmission. We have also a certain lower proportion of transmission occur through contact or droplets coming on the surfaces, and these surfaces becomes contaminated, and then the next person may touch these contaminated environment, and then he or she may touch his nose, mouth, and other mucous membrane, eyes, for example, and then this is how the transmission occurred. So we have also the contact transmission as a possible route. We have also very few difficult to quantify proportion of cases, particularly occurring during aerosol generating procedure, the medical procedure in the healthcare facilities like tracheal intubation, non-invasive ventilation, for example, cardiopulmonary resuscitation, open suctioning of respiratory secretion, for example, in some settings. So these are associated with lots of aerosols, and this is these aerosol generating procedures might transmit infection through aerosols and not through larger droplets. So we ask healthcare workers attending those aerosol generating procedures to wear specific masks, which is the N95 or equivalent masks, but all other routine situations, we ask healthcare workers to wear the surgical / medical mask. So WHO is promoting 5 strategies to limit the spread of COVID-19 in healthcare settings. The first and most important one is standard precautions for all patients. And let me tell you frankly that through our communication and with many countries in our region and also elsewhere, this is the most important factor and this is how many healthcare workers get contaminated and get transmission, because they unfortunately they sort of like neglect this important strategy, standard precaution. The other strategy is screening and triaging, additional transmission-based precaution when we know that this patient is suspected and not confirmed COVID-19, plus administrative controls in the healthcare facility, environmental and engineering controls. I'll try my best to go very quickly through all of these if time allows. The standard precautions is very important. We should practice them with all patients, regardless of their whether we know or we don't know their infectious status from any infections. We should do this all the times with all healthcare workers in all the healthcare facilities. And these are the elements of standard precautions. I'll try to cover at least the most important and most relevant to COVID-19, like hand hygiene and respiratory hygiene. Hand hygiene, very important, very effective, very simple, and very cost effective as well. We have 5 moments that the WHO promote. Cleaning your hands with alcohol hand rub or washing hands with soap and water before touching the patient, before conducting aseptic procedure, after body fluid exposure risk on the patient, after touching the patient, and or after touching the patient surrounding, whether with soap or alcohol-based hand rub, your hands could be clean. Respiratory hygiene is another important standard precaution, and very effective, also very important in these times of COVID-19 pandemic, and because also we are entering towards the winter time. So again, this becomes more and more important. We ask whoever is sneezing, coughing, to cover their mouth and nose with tissue, or if they don't, to cover, to contain the secretions in their elbow. And then after that, they clean their hands and they have tissue to do dispose them in a bin. And if they can afford visitors and patients coming to healthcare facility, they should also wear masks. The second important strategy is screening and triaging. We should have, in addition to clinical triage, we should also establish screening and triaging of patients with respiratory infections. We should have adequate space for triaging, and we should install and start and establish this triage in the primary entry points to the healthcare facility. For example, emergency department or emergency room, outpatient clinics, or any other points of entry to the healthcare facility. Have space for triage. If possible, we should have a kind of barrier between healthcare workers and patients encountering these entry points at the healthcare facility. Hand hygiene materials should be available, and masks as well. And we have specific area that we could put patients with respiratory symptoms aside from any other patients. And also we should have a fast track so that those patients with respiratory symptoms get medically evaluated as quick as possible, and then the next step after evaluation is done very quickly. We should have clear signage in the language, the local language, and that people can understand. And we should also have signs for family members not to accompany cases which have respiratory symptoms. Then the next steps of triaging, of course, with admission, with specific clinical management according to the protocol available at the healthcare facility. The third strategy is transmission-based precaution. We talked about standard precautions, we talked about triaging. Then if we suspect or have a confirmation that this patient is a COVID-19, then we apply the additional ones, and this based on the mode of transmission I just described in the flow slides before. So mainly we apply contact and droplet precautions for all the routine work or the routine medical procedures on COVID-19 patients. Only when we have aerosol generating procedure that we apply airborne precautions. So this is in the form of single room, adequate ventilation, space, good space between beds, at least 1 meter, separate toilets if possible, signage that this is that these patients are on droplet and or contact precautions, appropriate personal protective equipments, and so forth.
2 minutes, doctor.
Sure. So as I said, in most of the routine procedures, we implement or we implement droplet and contact precautions in the form of medical mask, gown, gloves, eye protection, either goggles or face shield. And in the extreme situations where we have aerosol generating procedures, all healthcare workers attending those procedures should use, instead of the medical mask, should use a fit tested N95 FFP2 or equivalent, and in addition to the other personal protective equipments. I don't have time to go through all of the personal protective equipments, but very important key points. These are procedure specific. We usually put them only when we are doing the procedures and take them off after the procedures. But of course, we know that of the situation of COVID-19, there might be situations where we wear them a longer time, but we should be very careful when we wear them, and also when we take them off, and always perform hand hygiene before putting them and taking them out. WHO has developed some guidance on the rational use of personal protective equipments, encourage telemedicine, encourage use of physical barriers, try to arrange the work ahead so that you minimize the use of personal protective equipments, and don't allow visitors if you have shortages of personal protective equipments. We have also online materials available on how to put on and remove personal protective equipments. In the extreme shortage, there are certain guidance that we have developed on how to manage these extreme shortage. We have also some administrative measures for healthcare workers, like separation and environmental cleaning and adequate ventilation. These are examples of the online courses that WHO have developed. They are available free online and also self-paced, so you can navigate through them into your own speed. Finally, these are the reference of my work, of my presentation, and thank you very much for your time. Over to you, Dr. Najiba.
Well illustrated presentation about the IPC in the context of the pandemic of COVID-19. Give me now a great pleasure to introduce our next speaker. He is Professor Paul Tambyah from Singapore. He is a professor of medicine at the National University of Singapore. He is a senior consultant in infectious disease in the National University Health System in Singapore. He will tell us about the Singapore experience during the COVID-19 pandemic. The floor is yours, Professor.
Thank you very much for inviting me to do this presentation. Just trying to get my screen set up. Good. So I was asked to put in some learning objectives. So I would like to explore the epidemiology of COVID in a wealthy city-state with a large migrant worker population, recognize the modes of transmission, although I realize the previous speaker covered that very well, and appreciate the need for holistic COVID coverage, especially in vulnerable populations. First off, I'd like to admit that many of us underestimated the virus. Now, I have a concomitant appointment at the National Center for Infectious Diseases, and one of the things that we do is we give small travel fellowships. So we gave a travel fellowship to a scientist to visit the Wuhan Institute of Virology. This was awarded at the end of last year. And she wrote to me in January, and she said there was a recent emerging virus in Wuhan spread all over China. She canceled her trip, managed to cancel hotel, and asked for a reimbursement of the air ticket. Now to my eternal shame, I said I will not try to reimburse. I will reimburse her if she can provide documentation that she was told not to go. If she's just scared of getting pneumonia, we should not reimburse her. Of course, you know by now there are more than 30 million people infected with the virus, with more than 1 million deaths. Now, I am primarily a clinician, so this is a patient that we looked after. 72-year-old healthy woman with only mild diabetes. She felt unwell with some dizziness, but went out with her friends, became drowsy on returning home, collapsed in the ambulance, was resuscitated and intubated. When she got to the emergency department, she had a CT scan, which for those of you familiar with seeing CT scan shows a massive bleed in the back part of her brain. She was terminally extubated because the prognosis was poor and they wanted to palliate her. But an alert emergency department doctor noticed that her x-ray didn't look anything like somebody with an intracranial bleed. So asked me whether we should test for COVID, and we did. It turned out positive. Because we were not sure about it, we even did a serological test, which was positive as well. She passed away, and this was reported in the media. However, she was not counted as a COVID death because Singapore rigidly follows the WHO criteria considering only pneumonia cases as COVID deaths. And as a result of which, mortality data are very hard to compare across countries. In fact, globally, mortality is primarily age-dependent everywhere. The age-specific mortality rate in Singapore among those over 80 is 20%, which is very similar to the rate in Italy, China, South Korea, or Spain. Similarly, the incidence data is very hard to compare. If you go to the website Our World in Data, you can put in your country, and you can see. I was delighted to see that finally Singapore dropped below the United Arab Emirates in terms of the number of confirmed cases per million people yesterday. But again, it's very hard to compare because there are different levels of testing. And in fact, testing seems to be very closely correlated to GDP, with countries such as the Emirates just above this line and countries like Singapore just below the line, but a very close correlation between GDP and the number of tests per 1,000 people. Now, our patient, the lady, she passed away from an intracerebral hemorrhage. And one of the things that we've learned about this COVID disease is that it's not just a lung disease. It is not just the atypical pneumonia where we've got the alveolar macrophages involved, but it also involves thrombosis or blood clots and dysfunction in other kinds of blood vessels in the brain, as with our patient, and also in the heart. So this is a patient that we had. Young man, 22-year-old from a dormitory, a South Asian migrant worker, fever for 5 days, dry cough, loss of smell and loss of taste, had red eyes, high fever, low blood pressure, very high heart rate, COVID positive 2 days prior to admission, chest x-ray, no evidence of pneumonia, but the heart seemed to be big. And he had this mottled appearance of his skin. This is the dormitory he came from. His ECG showed hyperacute ST elevation, or what would have been thought of as an acute heart attack. His C-reactive protein was very high. His ferritin was also very high, and these are markers of inflammation. His lymphocyte count, one kind of white blood cell, was low, and his 2D echo showed various wall motion abnormalities suggestive of severe heart damage. He was managed conservatively, and he managed to do well, so that was fortunate for him. Now, these cases are atypical. A far more typical case is this one, 38-year-old administrative worker in the hospital. She felt unwell early in February, saw her general practitioner, was given clarithromycin, some rest at home. She developed a bit of shortness of breath, came to the emergency department, was sent home again. She wanted to come back to work, but she had a PCR done, which was positive. So she was admitted, but by this time she was completely asymptomatic. And she stayed in hospital for 10 days because that's what we did at the time, until she had 2 negative swabs before she was discharged. What is interesting about her is that she was contact traced, and she could be traced back to introduced cases coming in from Wuhan into Singapore. And this was in the early part of the epidemic when Singapore had really good contact tracing. Every single case was traced. We got multiple contacts using multiple sources, and we were able to link every single case to imported cases from visitors. What is interesting, though, about the chain of transmission that she was part of was that they couldn't find the link originally until they actually did closed-circuit TV watching of the church, which a family member of hers attended. And what happened was there were a few visitors from China attending the church service. They left immediately after the service, and there was closed-circuit TV camera. Now, don't ask me why they put closed-circuit TV in the church. Maybe they thought people were taking money out of the offering bag. And these people had no contact with the secondary cases, but they occupied the same seat. Now, I know there's a lot of people who don't believe in fomite transmission, but these people had no contact. They didn't share the same air supply. And so I think there is some possibility of fomite transmission here. Now, the contact tracing team contacted 191 members of the church, and they tested 6 of them. They found those who were unwell, and none of them were positive. So if this virus was airborne, it must be the world's least efficient airborne virus. But why do people still believe in airborne transmission of the virus? And I'm glad that your previous speaker mentioned that it's primarily during aerosol generating procedures. The rest of the time, as far as we know, it's close contact or droplet. Now, the miasma theory reigned in medicine from the time of Hippocrates to Louis Pasteur. And this has recently been fueled by this paper in the New England Journal of Medicine, where they showed that the virus could remain airborne for 3 hours in small particle aerosols. But I always tell my students to read the fine print. And if you do read the fine print, you realize that the virus came in high concentrations from a high-powered nebulizer into a special chamber used for detecting bioterrorism agents. So in very controlled laboratory conditions, yes, the virus can stay in the air for a while. In contrast, in real life, in our National Center for Infectious Diseases, despite multiple places of contamination of surfaces, including chairs, windows, toilet bowls, sinks, there was no positive air samples that were taken using a very similar methodology to used elsewhere. Now, the group from Nebraska, who are leaders in airborne isolation, they also found multiple RNA samples positive from the air, but no culturable virus. And this was the case for a very long time until just recently in September, when a group from Florida published the detection of airborne virus in 2 patient rooms. Now, what is interesting is one of these rooms had a patient who had a negative swab test, and he was in the process of being discharged at the time the air sampling was done. So this is very odd. The patient doesn't have any virus, but there's virus detected in the air, and it still hasn't been completely explained. So there was this group of 239 scientists who criticized the WHO for not accepting airborne transmission. Now, I like to think that they wanted to have 240, but I refused to sign the letter because I didn't believe in aerosol transmission. I may be wrong. So the WHO and CDC have been in the firing line. The CDC published guidelines on aerosol spread, which they withdrew, and they have republished them, pointing out that it does occur, as the previous speaker said, in rare situations where there's aerosol generating procedures. Because this is important, because if the virus is really airborne, medical masks are useless. You need N95 masks. And if people walking down the street or in a bus or in a restaurant are going to be breathing out airborne virus, we should all be wearing N95 masks all the time. Now, this was a huge issue during 2009, H1N1. And in fact, I was at a session in IDS, chairing a session in IDSA, when a paper purporting to show that N95s are superior to surgical masks was retracted. So the IDSA and SHE presidents wrote to President Obama, and I'm sure the poor man had a lot more things to worry about, but that was how important it was. During SARS, N95 masks were widely used in Singapore. In fact, even bank robbers used them to rob the bank, but they found it uncomfortable and put it on their head. Fortunately, after H1N1 2009, surgical masks now dominate, and even the bank robbers switched from N95s to surgical masks. So during the influenza A H1N1, that was me. I insisted on using a surgical mask because I did not believe that ordinarily the virus was airborne. Like SARS though, SARS-CoV-2 is not easily spread by most people who only infect 0 or 1 people, but there are these so-called super spreading events which occur. In Taiwan, most transmission has occurred in households rather, with no transmission at all in healthcare and limited transmission in families. The same has been true in India with a large study of 575,000 tested contacts. However, super spreading events have been reported, and we've looked at this, and we find that it's primarily within households, and especially in the dense migrant worker dormitories in Singapore, where there are large households, and we wrote this in March 2020. So the migrant worker dormitories in Singapore are extremely crowded. You've got 15 to 20 people in a room, so effectively it's a huge household. And the initial cluster of cases in migrant worker dormitories in Singapore were managed very well. Contact tracing, quarantine of contacts, no spread beyond the first 5 individuals, and this was in February. However, as the cases built up dramatically, in order to prevent the local healthcare system from being overwhelmed, what happened was primary care teams were sent out to the dormitories. They were deployed without chest x-rays or even point of care testing, and they used clinical features to try and identify patients who are symptomatic. And this was published in the Journal of Hospital Infection. There were also attempts to preserve the main healthcare system. And in fact, the Ministry of Manpower sent an advisory to employers not to send workers to hospital unless it was an emergency. And there were unintended consequences as the outbreaks in the dormitories spiraled out of control. And what happened was the dormitories were locked down so that the workers could not transmit the infection to anyone outside the dormitories, but the construction industry, the marine sector in Singapore ground to a halt because they're very dependent on migrant workers. And what happened was each dormitory became like a little cruise ship. And you know what happened with the Diamond Princess, where the populations in the port in Tokyo and Yokohama were protected, but the passengers on the cruise ship slowly, one by one, began to get infected until they put in interventions. So there were extraordinarily high attack rates in the dorms. Again, from the same paper, there were 1,800 out of 5,900 workers were symptomatic. Of the 1,800 which they tested, 69% of them were found to be positive, which is probably one of the world's highest positivity rates, 69% out of the symptomatic healthcare workers. Now, the symptomatic is only part of the problem. Don't forget, there's another 30% of them who are, the significant number who are asymptomatic. And in January, there was a paper on asymptomatic transmission. And science, published in the New England Journal, Science claimed that this paper was flawed. They also claimed that somebody was going to write to the New England Journal to criticize the paper, but that never happened. And in fact, just in the last month, Camilla Rothe, who wrote the paper, Transmission of COVID from an Asymptomatic Contact, she was named as one of Time Magazine's 100 most influential people in 2020. So in Singapore, we have this outbreak of imported cases at the beginning, and now we've got more as we've opened up the borders. We've got cases with local transmission, which have been relatively few, max of 60 a week, but we've had explosive outbreaks in the migrant worker dormitories, more than 1,000 on at least 2 occasions, or 1 occasion, with another occasion getting very close to that. So this has revealed what the BBC called a pandemic of inequality, where people in Singapore live very comfortable lives, like in many cities in the developed world, whereas the migrant workers lived in very closed and cramped conditions. So the concern was that, what are we going to do? Are we trying to breed herd immunity? Now, we don't know whether we have achieved herd immunity or what level of immunity is necessary. But when you've got such large numbers of individuals infected, there's a good chance that there will be lasting immunity. And this is a paper that we did where we looked at people who were infected with SARS 17 years ago. Many of them were healthcare workers. They came forward to volunteer their own blood. And what we found was these SARS-infected people still had antibodies which could T-cell responses actually, which could respond to SARS-CoV-2. So it suggests that potentially there's long-lasting immunity, T-cell immunity, long after the antibody titers have waned. Trouble is, T-cells immunity is hard to measure, unlike antibodies, which you can do with a little kit. So what are we going to do with these migrant workers? They're stuck in their dorms. They're protecting the population by not going out, but they themselves are going to get infected. Now, during H1N1, we tried Tamiflu ring prophylaxis. So we actually conducted a large-scale clinical trial in the dormitories in Singapore, and the results are being analyzed and submitted as we speak. It's not just the infections themselves, but also the mental health issue. Can you imagine what it's like being locked in the same room with 10 to 15 individuals? You can't go out, you just have to stay there, depend on the Wi-Fi. And so mental health during the lockdowns has been very tough. There have been suicides, and in addition, there's been significant amounts of depression recorded amongst these workers. These are workers who are 10 to 15 per room with limited number of toilets per level or unit. And this continues even after the COVID is over, because we have to deal with, this has brought to attention the plight of the migrant workers in Singapore, and we realize they are generally outside of the healthcare system. And these are things that we're going to be forced to confront in the years to come. So ultimately, this outbreak has been a wake-up call for everyone in Singapore. While we have managed to protect a large proportion of the general population, its impact has been devastating on the migrant worker community. Ultimately, we used to live in a globalized world. We don't know whether we'll be going back to a globalized world, but the bottom line is that no one is truly safe until everyone is truly safe. Thank you.
Okay, I think we are ready to start the next session, session number 2. And I would like to welcome the first speaker, Dr. Ashraf El Houfi, who is going to talk about antibiotic stewardship guidelines bedside. So Dr. Ashraf El Houfi is a consultant at the ICU and chair of ICU at Dubai Hospital. And he is an examiner for the Royal College of Physicians in the UK and professor of medicine at Dubai Medical College. And he's the chairman of the Infection Control Committee at Dubai Hospital in the UAE. Dr. Ashraf, your talk, please.
Thank you very much, Dr. Jans. And thank you very much for all the audience for joining us for this virtual edition of the International Conference on Antimicrobial Resistance. In the next 20 minutes, I will be sharing with you a hot topic, hot topic because everybody now is talking about antibiotic stewardship. But I will tell you what I will do and what I will not do. What I will not do is talking to you about the basic science behind the antibiotic stewardship program, or the components of the programs, or what is the beneficial effect of this program on both the antibiotic prescribing and the microbial resistance. But what I will do is I will give you our experience in Dubai Hospital. How did we manage, despite not all the components of the antimicrobial resistance program are available in Dubai Hospital, that how can we make it possible how to do it. It's stuck. It's not advanced. Okay, so those are some of the learning objectives. And I'd like to talk to you about the theme of the presentation. As you can see, we are actually fighting the clear and present danger, which everybody is aware about it. And this clear and present danger is the presence of lots of dangerous bugs, and we are running out of drugs. I think this is a clear fact, we all know about it, that the antibiotics are decreasing. We don't have new molecules of antibiotic. Every new antibiotic we see is just a newer generation of an older generation, or a newer class of an older class. So actually, you can say that the shelf is almost empty. And the second problem is the significantly increasing bacterial resistance, both in gram-positive, gram-negative, inside the ICU, outside the ICU, in the Middle East, or in Europe. So it is a global problem which we are facing nowadays. I always describe this as the deadly combination. The presence of serious infection in association with increasing bacterial resistance and the antibiotic misuse. So we need to produce the solution. It's not enough to keep on identifying the problem. We need to talk about the solutions. And the solution is definitely the antibiotic stewardship program. The problem, the people are perceiving the antibiotic stewardship program in the wrong way. They are talking as if we are trying to prevent them from prescribing antibiotic. We are trying to restrict the use of antibiotic to a certain group of people, allowing certain specialty to use it and prevent the other specialty from using, or allowing certain doctors to do and preventing others from doing. That's completely wrong. The main idea behind the antibiotic stewardship program is to optimize the use of antibiotic and try to decrease the unnecessary use, and hoping that this at the end will decrease the bacterial resistance. So in order to do that in Dubai Hospital, we have to answer three questions. The first one, do we have a problem? Because if we don't have a problem, then we don't have to find a solution. And if we have a problem, so do we need to put an antibiotic stewardship program, and then what program and how we can implement it? And we promised our colleagues that we will neither try to hide nor try to pretend as if we don't have a problem. So we make an initial survey to Dubai Hospital to see how bad is the situation. Look at the incidence of the ESBL producing Enterobacteriaceae like the Klebsiella or the E. coli in the inpatient and outpatient and hospital-wide. So almost 40% of our isolates were ESBL producing by the time we are starting this program in 2012. And we have this even more higher when we look at the inpatient. Almost 50% of the isolates were ESBL producing. So we definitely do have a problem when it comes to bacterial resistance. The multi-drug resistant, even matching with the data which is being presented to you with Dr. Jans before, it was not that high, but it is increasingly every day. The second question is, how our colleagues prescribing antibiotics on a daily basis? So we did that survey to know exactly what is the percentage of inappropriate antibiotic prescription. And to our surprise, we find that almost 44% of the medical and the patients in the medical ward, antibiotic prescription was inappropriate, and around 37% in the surgical ward inappropriate, around 32% in the pediatrics were inappropriate. So in average, 37% of the antibiotic prescription were inappropriate. So we can ask ourselves the same question again. What was the pattern of inappropriate prescription? we found that 50% of this antibiotic prescription was inappropriately chosen empiric. And to our surprise, that almost 1/4 of the patients started on antibiotic has no evidence of infection whatsoever. And despite the positive culture, we found that 40% of the prescriber did not even de-escalate, either remove one of the antibiotics or go to a narrow class of antibiotic. And another one which we found during using the prophylaxis, as you can see, that 12% only were abnormal or inappropriate when it comes to the class, but 97% it was inappropriate when it comes to the duration of the prophylaxis used during surgery. And when we make some consumption pattern in our hospital, we notice that we are utilizing in kilograms. We are 3 times more than the standard utilization ratio. So if we ask the same question again, do we have a problem? Definitely, we do have a problem in Dubai Hospital, and we need a program to solve this. Then, which stewardship program or strategy we should follow? Now, if I'm talking about the core strategies, those are the core strategies, but that's not what I'm doing today. What I'm doing is to tell you what did we do. So in phase 1, we adopted the prospective audit with feedback to the prescriber, because this is the most powerful core strategy in antibiotic stewardship program and the most effective one, despite it is the most difficult one. And we were planning to put phase 2. Well, I will show to you the result right now. The prospective audit, it is difficult because you need to do a daily review of the antimicrobial prescribed in the day before and give a feedback to the prescriber with the intention to either change, correct, or adjust. It is very essential. The advantage of it, it still keeps the autonomy of the prescriber. This means the physician will not be prevented from prescribing the antibiotic according to his clinical assessment. And it is also very important because the feedback which will be given to the prescriber will give him the chance to communicate with the antibiotic review committee. So he'll explain his side, and there is a productive, constructive discussion will improve the awareness toward the proper selection. The only disadvantage is that the compliance is voluntary. This means that he is not obligated to follow your advice unless you have an extra way of making it to happen. So the phases of implementation of the program which we did in Dubai, in order to avoid this problem with voluntary compliance, is we get the administrative support. Why administrative support? Because the physicians in the hospital need to understand that the advice given to them by the antibiotic review committee is coming from the hospital CEO. It is not a matter of personal differences between your opinion and their opinion in order not to increase the unnecessary discussions and argument. But if your administration is not very supportive, like any one of those, then it is very unlikely that you will be able to get any antibiotic stewardship program to become successful. The second phase of this is to find an antibiotic monitoring form. Why it is important? Because you need to find a simple form which will allow the prescriber to fill it when they are starting an antibiotic. And our major problem later on is how this will reach the antibiotic review committee. Because as you can see that we started this program back in 2012, it was before the electronic medical record entered Dubai Hospital. So we have to do the antibiotic monitoring form in a hard copy. Then later on, we make it as a soft copy. When we make it the soft copy, we created already certain folders for each department in order to be able to put the antibiotic form in it. We also agreed about something which was unique to Dubai Hospital, that the nursing staff attending the patient, executing the antibiotic, will be the one filling this monitoring form. This is something unique because the nurses are very committed. When you are asking them to do something, they always do it in the best way. The second thing is they are impartial. They are not part of the antibiotic prescription process. So they don't need to justify why the antibiotic was written. They don't need to defend the choice of antibiotic. They just mention the mere fact that this antibiotic was written, this is what is mentioned in the patient's file, and those are the indications which were done to those patients at this particular time. And we created a specific folder, as you can see, for each ward. So the nurses, after filling the antimicrobial monitoring form, they just inserted in each specific form where the review committee will be able to see those forms in order to review that. The third step was to build a team. Why building a team is important? Because this is a voluntary work. As I can see, I think that the presentation is a bit on hang. Okay, now we are back on track. So why we need a proper team to handle the antibiotic stewardship program? Because it's a difficult task. And this difficult task needs people who are dedicated and committed. We need people to be able to keep on doing the same job. And it's an exhaustive job in addition to their clinical work every day. Now, we know that in many hospitals, you may or may not have an ID physician. So antibiotic stewardship team lead can be from any other service, provided that he has a good knowledge about the antibiotic prescribing ability. Not all the hospitals are having the ability of providing a clinical pharmacist or clinical microbiologist. So you have to utilize the team who are available in your hospital, because this will help you to support. Why we need it to be coordinated? Because the positive impact of coordinated work is very important, because we don't want to reach this lower picture where everybody is working in his direction and the outcome will not be that good. And that was the folders for the antibiotic review committee, where they are assigned to review. Each one of those are supposed to review certain department, and then at the end, we have to give the feedback to the prescriber. So the third phase was to give a feedback to the prescriber. That was probably the most difficult one, because we need to give them the advice why we think that their choices were inappropriate with that explanation. And that's an example of the email which we used to send to our colleagues who are prescribing this antibiotic. Like this example, for instance, that the patient was admitted with what looks like a respiratory distress diagnosed as a community-acquired pneumonia, while the dominant feature was of a congestive heart failure, and the infection markers proved to be very low, and the NT-proBNP, which diagnosed the congestive heart failure more, is on a very high level. So we give them the advice that this antibiotic is not needed. It is well respected that their initial evaluation that this was an infection, but we know from the data it is not, and that's what we are giving to them the advice. The next phase was to make a data collection of whatever we did in order to see the effect of whatever we did on the initial data, which we already presented about this. And we can give you in the next couple of minutes what did happen. We started with an inappropriate antibiotic prescription in the medical ward of almost 44%, and we managed to reduce it down to 16% in the medical ward. In the surgical ward, we started with 37%, and it is now down to 18%. In the pediatric department, it started at 32% of an inappropriate initial antibiotic prescribing, which went down to almost 10%. And the hospital average, it started with 37%, which went down to 16%, which was a very effective strategy, showing that the prospective audit and the positive feedback to the prescriber will make a significant impact on the antibiotic prescription. When we talk about the antibiotic prophylaxis for surgery, we noticed that 97% in our initial survey was showing that there is a prolonged duration of surgical prophylaxis. We managed to reduce that down to 42%. And that was also effective as a method of treating it, which is very effective. So the second phase of our antibiotic stewardship program was the streamlining and de-escalation. And we are privileged that we have been supplied with some dedicated clinical microbiologists recently, and they were dedicated dedicated and committed to do the work. So they started to prospectively, on daily basis, review the culture report. And once they review the culture report, they follow the following process. They cross-reference the antibiotic prescribed for this patient against the microbiology culture, and then they send this data on daily basis to the antibiotic review committee and the chair of the infection control committee. And then the cases will be discussed, and then a feedback will be sent to the prescriber again. And this process need dedication, because this means the clinical microbiologists have to look into the cultures, cross-reference with the antibiotic prescribed, make a review to diagnostic criteria why this antibiotic is prescribed, and give some advice to the committee in order to give a feedback to the prescriber. And this is a sample of how they send me the Excel sheet every day, and you can see lots of data we can extract out of this. To my surprise, that when we were talking about the empiric choices that we decreased the inappropriate prescription from 40s and 50% down to 15 to 16%, that in the de-escalation process, we only needed to give a feedback of a change to the prescriber in less than 4%, which means that our team in the hospital started to realize that prescribing antibiotic is quite an important thing, and they need to pay attention to the cultures, and they need to de-escalate according to the culture, and they need to streamline. And we did not need to send the feedback except in less than 4% of the cases, not like our initial survey, which saw that between 30 to 40% inappropriate prescription. Do we have any further steps to talk about in the antibiotic stewardship program? I think there is a lot. We recently acquired also the molecular diagnostics. And once you have a rapid diagnostics, which will give you not only the organism, but it will also give you the mechanism of resistance in few hours, not in few days, that will streamline the choice of the antibiotic in a proper way. You don't have to wait for 48 hours to know if this organism is ESBL producing or a carbapenem producing, and this will make a great revolution in antibiotic choices. And there is one more step which is coming in the next few months, which is the complete integration between the rapid diagnostics in the microbiology and the pharmacy system with the electronic medical record, which will be able to give you an almost real-time assessment of the relationship between the bacterial resistance and its mechanism, as well as the drug which is being prescribed to the patient, so you can early detect the bug-drug mismatch and adjust the antibiotic prescription as well. So at the end of my presentation, I can just give you a question. Can the antibiotic stewardship program hold the tide of bacterial resistance, or we will keep on waiting till this tsunami will just take everything in front of it and we will not be able to have any chance? I think we can. Those are some references for you, and thank you very much for listening.
Thank you very much, Dr. Ashraf, for this great presentation. It was really very useful, very helpful, and it clearly showed how you implemented this in your hospital and the great achievements you have achieved, basically. So thank you so much. I'm just looking if there's any questions here from the chat. For example, there was one question regarding how to implement such ASP program in primary healthcare settings. So, I mean, you talked about Dubai Hospital, and as a hospital, you have other opportunities or resources, but can you maybe comment on how this could be done in a primary healthcare setting?
Yes, it can be. It is the same way. You will still need a committed team to look into the antibiotic prescription by your fellow colleagues in the PHC. And they have to cross-reference this to why the antibiotic was written. Was there indication for this antibiotic, or it is just prescribed because they want to make the customer pleased? And the feedback will be given to them either sporadically or on personal basis or collectively. And this will definitely improve the antibiotic prescribing, which we call closing the loop. You should give the prescriber the idea that whatever he is doing when it comes to antibiotic prescription is monitored. So it is not just I'm responding to a patient request that I should start an antibiotic for a headache or for abdominal pain because I'm afraid that the customer will go and complain. You have to have a clear justification of why to start an antibiotic. So it's the same process. You need to build up the team. You need to monitor the antibiotic prescribed. You need to give a feedback to the prescriber because this will improve the way the antibiotic is prescribed.
Thank you very much. And I think we have still time for one or two more questions. So one question I see here in the chat is, dear Dr. Ashraf, did you develop or use a standard form to label inappropriate use of antibiotics? Can you please explain this process? How did you do this?
Yeah, now we, as I saw, the antibiotic monitoring form was filled by the nurses, which contains certain data about the patient and what is written in the patient file about the indication. And this will be sent to the antibiotic review committee. So they only fill the form, put it in the specific folder, which is for their department. And then the antibiotic review committee will be the one looking into it. They look into the patient, see about the indication for this antibiotic which is being prescribed, and then the antibiotic review committee is the one deciding if this antibiotic prescribed is appropriate or not. And then accordingly, we send the feedback to the prescriber about our information. Sometimes the prescriber starts the antibiotic early while everything is still blurred. He doesn't know much information about the patient, but for the committee, we have the advantage of looking at the chest x-ray, about the infection markers, about initial gram stain or culture report. Then when we give the feedback, we give that is not inappropriate, but it was inappropriate to chosen based on the information available for the prescriber at the beginning. So it's not that we are telling he is inappropriate, but it is an inappropriate selection based on the data available at that particular time. But it is the antibiotic review committee is the one deciding if it is appropriate or not.
Okay, thank you very much. And there's one more question: how to adapt a stewardship program to a long-term facility where 70% of patients are colonized?
Yeah, this is a very good one. Here we have to make sure that we are not treating a culture report. Of course, you're a professor of microbiology, you know that better than me, but one of the major problems is the longer the patients stay in a facility, the more likely they will be colonized with bacteria. So the message here will be, do not treat the culture. Treat the patient who has signs of infections with the help of the culture. So it is not an automatic response to an ESBL isolated from any urine sample or a CRE taken from a tracheostomy sample, that now I have to go to a high ceiling antibiotic. I have to make sure that this patient is having signs and symptoms of infection. I have to make sure that I use the biomarkers to help me in that diagnosis before shooting this resistant organism with more powerful antibiotic, which will create more resistance in the future. So I think it is even more important in the long-term care facilities because more resistance will happen because of the much more use of the antibiotics.
Thank you so much, Dr. Ashraf. This is really very helpful. And I think we have to move on to the next presentation. And it gives me a great pleasure to introduce Dr. Hanan Balkhy from WHO. She's an executive director at WHO and talks about the AMR in the light of COVID-19 pandemic. Dr. Balkhy is executive director also of the Infection Prevention and Control Unit at the Ministry of National Guard Health Affairs in Riyadh, Saudi Arabia. Dr. Hanan, the floor is yours.
Thank you very much. Thank you, everybody. Thank you for the introduction. Just a quick correction. I am no longer in Saudi Arabia. I'm the Assistant Director General for AMR at the World Health Organization here in Geneva. So welcome, everybody. And thank you, Dr. Abdulrazzaq, for the invite. So again, this conference I think is very important, and I think I want to pick up on my colleague Jameela's comment about burnout. I think burnout can happen in every single situation, and I think many entities of the AMR response can have quite a problem with burnout. Again, maybe I'm going to be giving a little bit of a global perspective of antimicrobial resistance and move a little bit away from the healthcare sector. And I think the best way to start is to understand the complexity of antimicrobial resistance and how complex this story is, where you have the 70% of antimicrobials produced are actually utilized for the animal health. And yet there's another problem where the overlap between the usage in what is used in agriculture and plants and animals is also sometimes used in humans, which allows for more pressure on the bacteria and the emergence of resistance. Now, in the unintended exposure to antimicrobials, so it's the proper use, which you've heard very eloquently about stewardship, but there's the unintended exposure to antimicrobials through the food chain, through water, through the contamination of water and food from the effluent of pharmaceutical companies, from using antimicrobials in the feed, from it seeping out into the environment. And I think this picture kind of shows you the different aspects of AMR within that environment. This is a slide again that just shows you some of the overlap between human, animal, and plant, and how there are specific antimicrobials that are used between the three sectors. And that again helps put the pressure and the emergence of antimicrobial resistance. Now, the issue of AMR is not new to any of us. And I think those of us who read the history understand that from the very first identification of the chemicals that kill or prevent the growth of pathogens, from that very beginning, there was the issue of antimicrobial resistance. And it was very interesting going through the catalog of WHO. For another reason, I found that at the very beginning, over 70 years ago, during the establishment of the WHO initial mandates, the very first 5 mandates, one of them was actually stewardship and to prioritize proper use of antimicrobials. There has been, as I like to describe it, the topic of antimicrobial resistance has been on and off the bandwagon multiple times, and it loses the attention or the global attention because the topic is very difficult to explain, very difficult to comprehend. It's not something that has one single face to it. It's not smallpox, it's not polio, and it's not something that's used commonly in even bioterrorism so that it can get that political attention. But I don't want to go back and talk about the history over the past 70 years, but just to identify what has been going on specifically over the past several years. There was in 2011 an AMR World Health Day that really did not pick up much, but more so the started in 2015 when there was the Global Action Plan resolution at the World Health Assembly. Very quickly the following year, the United Nations General Assembly declaration of establishing the Interagency Consulting Group known as IACG, for which I was a member on this committee for 2 years, and the endorsement and the signage between FAO, OIE to endorse the Global Action Plan. The IACG was established in 2017, and tripartite assessment of countries' response was starting to be collected, started slow, I'll show you some data, and the WHO's platform for collecting information on antimicrobial resistance was also established. In 2018, a memorandum of understanding. Again, now you understand why we talk about tripartite when we talk about AMR, because of the complexity of human, animal, plant, and environment and water in the response, and the need for such a memorandum of understanding to be between the three. The work plan was also developed for 19 and 20, and in 2019, another WHO resolution supporting the AMR action plans, and also a division within AMR, within the WHO, was established, for which I've been appointed as the first Assistant Director General for the division of AMR. Within this AMR, in implementing quickly the IACG recommendations, we established the Tripartite Joint Secretariat, which is really to align the three different agencies in their work on the ground within the countries to establish their national action plans and to enhance and catalyze the multi-sectorial work within the countries to address the complexity of AMR. At the same time, so this was very quick, the Secretary General was very supportive of the report and was very keen on moving it forward. And again, without implementation on the ground, AMR is only theoretical, and hence we started the multi-partner trust fund was established with 3 initial donors leading to $13 million, where we have some really good projects that will be launched very soon at the country level to support the work. Now, again, when I mentioned the complexity, the lack of a very strong global governance for AMR, which is coming soon, but again, there needs to be a reason for the countries to prioritize AMR versus the many other competing health agendas. And in order to do that, the SDGs, as you know, the Sustainable Developmental Goals, have added last year 2 additional indicators specifically related to AMR, which serve SDG number 3, which is looking at the percentage of bloodstream infections due to ESBL bloodstream infections and MRSA bloodstream infections, and try to reduce that by 10% at the country level. The second indicator is to look at the patterns of prescription or consumption of antimicrobial agents, where more than 60% or around 60%, which is the target for the usage of antimicrobials in a country, to be within the access group of antibiotics. And I'll get back to that to explain it further in a future slide. So what actually happened is that, as you remember, 2015, we had the 5 main strategic objectives of the global AMR action plan: improving awareness and understanding AMR, strengthening the knowledge through surveillance and research, reduce the incidence of infection, optimizing the use of antimicrobials, and finally developing the economic case for sustainable investment and increasing investment specifically in new medicines, diagnostics tools, vaccines, and other interventions. Now, those of you who have worked at national and subnational levels and trying to bring these high-level guidances and action plans to the reality, there needed to be more explicit guidance on how to do this work, how to explicitly go forward with it. And there are several frameworks and manuals that were developed between 2016 until today, and some of them are showing here on the screen. One of them is a working paper on multi-sectorial coordination. First of all, the manual for developing your national action plan, and a global monitoring and evaluation framework. How do we feed back to the politicians and seniors within government on how well things are working, and how do we benchmark and compare one country to another if it is worth that kind of comparison to catalyze the work, and also the implementation and coordination on AMR. Those of you who have been working at establishing a national action plan will probably be familiar with the TRACS report that is produced every year. And we were able to show that the national action plans were developed very quickly in 93 countries, or 48%. However, if you look at the smaller, the light blue, for each of the 3 periods I'm showing on this slide, you can see how many of them were funded. Now, costing and funding a national action plan is really a much higher level of taking this very seriously. And I think we're going to be working much stronger with the countries on how do we establish that costing and funding process to ensure that the documents that are written to identify the national action plan, whether it's the multi-sectorial work, the committees that need to establish, that are actually being executed. Again, AMR and surveillance is extremely important because, as I mentioned earlier, there was this lack of strong governance, strong global leadership on keeping the agenda of AMR under the spotlight. And in order to do that, we need to inform by data. We need to inform, since we don't have a specific, this is not one specific disease. And all of you here on the call probably know how difficult it is to unify microbiology services, how to unify and produce an antibiogram even for one healthcare setting. It's very challenging, and to have it updated. So this is a very complex platform, a very detailed slide that I show you here, where we have the GLASS AMR, which is the very initial one of the platforms established to engage the countries on strengthening their laboratory capacity and to report on resistance patterns for specific high or critically important pathogens. And the second one is antimicrobial consumption surveillance. And in blue, we're starting to pilot some of the more additional platforms, including enhanced gonorrhea surveillance, point prevalence surveys on antimicrobial use in hospitals, and very importantly, One Health AMR surveillance, assessment of the attributable mortality for AMR. One that's coming up very strong even in the Gulf regions is the Candida surveillance, because of the Candida auris, which has become somewhat of a problematic pathogen in healthcare facilities over the past years. Another one that's important is emerging antimicrobial resistance reporting. And this is something that to me would be a dream come true, to be able to identify emerging pathogens at a very early stage, implement intervention procedures and ways of identifying them quickly within the laboratory system, so that these pathogens do not become endemic the same way we saw this happening in the ESBLs and CREs and Candida auris and probably others. This is to show you the GLASS report, that the issue of the two indicators that we're talking about that we've prioritized in the SDG indicators, the third generation or ESBLs, E. coli and MRSA, we want to highlight here from this report that this is not just a problem of high-income countries, which some countries assume that AMR is a high-income country problem, when the reality it's a low, mid-income country and low-income country problem. So it's really a global issue that we're actually facing. This is again to show you the variation in resistance among the different countries for very critical agents, cefepime or third and fourth generation cephalosporins. Quinolone, ciprofloxacin is here, imipenem, mero, and erta from the carbapenem group. And you can see the red dots are the different countries, and some of the resistance in these countries for this pathogens is above 80% for the carbapenems. Some of them are reaching and exceeding 50%. So again, this is very scary information for those of you who are at the bedside, treating patients in real time. Antimicrobial use with COVID. I think you've heard enough about maybe with COVID and without COVID, but this is just 3 examples. There's many more papers that came out since I prepared this presentation. Bottom line from much of the literature is that patients with COVID, less than 5 to 10% of them actually have a co-infection with a resistant pathogen, yet 70% and above are receiving empiric therapy. And I'm not sure, I haven't looked closely enough to understand if there were de-escalation programs established for these patients to remove broad spectrum or to give more focused therapy in case they were identified to having a specific infection. So this is also problematic. I think it would be really important for scientists and researchers to look much closer into the situation of antimicrobial use in light of COVID. We tried in May 2020 to be more explicit in the revised clinical management of COVID-19 published by the WHO, which we give more explicit language about not using antimicrobials for treatment or for prophylaxis for suspected or confirmed mild cases. So if this is a viral illness, COVID or not, or other viral illness, we always say do not use empiric therapy for mild cases. Suspected or confirmed moderate cases, unless there's a suspicion of bacterial infection. And definitely it should be, antimicrobials should be used in cases where we're worried about beginnings of sepsis, yet this needs to be based on strong clinical judgment, patient and host epidemiological factors, and also to be very clear on ways of making a more focused diagnosis and to de-escalate when necessary. Now going to maybe this is more of a guidance that was produced that has two faces to the same coin. Whenever I talk about antimicrobial resistance and the problem with misuse and emergence of resistance because of misuse and exposure, we also worry about antimicrobials not being available for those who need it. So there are countries that don't even have the first-line therapies for your commonest syndromes accessible to the prescribers. So this AWARE list, which is access, watch, and reserve, 3 different categories of antimicrobials, where access is considered our generic first-line therapies. Watch group is more of the broader spectrum and more second and third generation antimicrobials, and reserve group is those last resort treatment options where high resistance is expected. So this is the indicator where when we encourage countries to report on an indicator that says 60% of the prescription, which means you have to measure the prescription at the level, should be within those access group. Because if it's more than that, then you know that you're using much broader spectrum antimicrobials. So the report on surveillance of the consumption, we were able to classify the usage among the countries who were able to report. 65 countries reported in 2018, and we are classifying and benchmarking the different patterns of usage. And as you can see, many of them are still highly using access. Yet some countries, this is only 6 out of the 65. It would be nice for you to go back to the report and see if your country is part of this report. We were very excited last year to be ready to launch the Antimicrobial Stewardship Toolkit, which gives guidance for national and subnational levels. Please access it. It's on our website. We do know that this is the first edition of this toolkit, and we're hoping that once it's rolled out and launched, we will be able to update it with even more specific guidance and experiences and lessons learned from the countries. But I think I won't elaborate too much because I think this was core to many of the other talks for today. The IPC and the COVID, again, I can talk about IPC for at least a full hour, but I think what I wanted to say here is that infection prevention and control is a tool that you're gonna need all the time, every time with every single pathogen. So it is being highlighted, as you know, my IPC colleagues on the line, is that every time we do have any kind of outbreak or when there's a cluster, and no wonder during a pandemic, infection prevention and control becomes highlighted big time. Same thing happened again here. The WHO had launched 12 technical guidance accompanied by risk communication resources, plus input into cross-cutting guidance documents. So IPC in schools, hotels, public health, travel, inter-agency guidance. Training has been ramped up significantly with an IPC channel on Open WHO platform with over 20 IPC, COVID, and other IPC courses in multiple languages. At the time of preparing this, there was at least 1 million enrolled with many webinar series. A lot of IPC research is also happening, and it was one of the 9 pillars that took place for the COVID R&D roadmap with 6 living systematic reviews to inform on guidance and multiple expert networks who are working on this, with a major focus also at the beginning. I think it's still troublesome, the percentage of healthcare workers that are affected by COVID, when healthcare providers would make up no more than 3% of a population, yet 14% of COVID patients are healthcare workers. Now, acquiring it in the community or within the healthcare setting is a question that needs to be answered. And again, how do we protect our healthcare worker to protect the healthcare systems to be able to get through the COVID pandemic is an extremely important question. Again, the tools needed for implementing IPC are common PPEs. Again, we also need diagnostic, therapeutics, and vaccines, but a consortium with WHO and significant co-conveners, including Global Fund, UNICEF, Gavi, UNITAID, had come together to create the COVID supply chain. One of them was specific for PPEs, another for also oxygen and medical devices. And as you can see, the amount of shipments to 170 countries and more were in the millions. The question then comes, how are these PPEs being used? How are they being used appropriately? And how do we make IPC, the way I like to put it, how do we make IPC practices part of the healthcare provider's DNA? So again, that's something that is definitely worthwhile looking into. There are several new and ongoing priorities for IPC. For the sake of time, maybe I will skip this slide because I touched on some of them, but I want to go to the research agenda because this is a very important topic. Again, the frustration that prescribers have at the bedside with running out of options to treat their patients, and there's a reason for that. The research and development has slowed down significantly, with over the years at least 12 major companies exited the antimicrobial R&D work, and that is very scary because again, novel antimicrobials is different than identifying new antimicrobials from the classes that we already know. The question is, and here I want to pose the question to the researchers and scientists, is we would be solving the AMR problem much quicker if we were able to separate between usage between animals, agriculture, and that of human. Then we can focus on the human interventions, which include IPC prescription. But now we're facing it from all directions, if you will. So in order to guide the research agenda, the WHO is produced in 2017 to be renewed soon, not this year, the priority pathogens to help identify for the research agenda what are the priority pathogens. Those that are lurking in the healthcare systems, including Acinetobacter, Pseudomonas, and the Enterobacteriaceae group are considered critical priority pathogens. And we have high priority pathogens, including Enterococcus faecium, Helicobacter, Salmonella, Staphylococcus, Campylobacter, Neisseria gonorrhea, and medium priority, including Streptococcus pneumonia, H. flu, and Shigella. Now that, again, we go to the next step, which is the WHO producing two main documents, a preclinical one looking at the antimicrobial pipeline and a clinical one looking at what is actually in clinical trial and what is being investigated. And these two documents are produced on an annual basis. So the 2019 document, you have the link to the site, and I'm happy to share my slides. You have 145 entities developing 252 antimicrobial products. So this looks very promising, looks very good, but in the clinical pipeline, we only have 32 agents for the priority pathogen list. Only six of them are innovative, and only 2 of them are against the critical gram negatives. So that's when we say that the pipeline is still dry. It's because of this data that is shown in these 2 documents, and these are to be updated on an annual basis. We've also produced to help the return of some of the companies to, or the researchers to investing in antimicrobial development is the AMR financial model, which was produced early this year, developed to support setting up an impact investment fund for the development of new antimicrobials. We're also prioritizing pathogens, moving a little bit, or adding, not moving, but adding to the energy for the AMR work at WHO is to create the priority fungal pathogen, as this also seems to be a big problem. So WHO had played a major catalytic role in the creation of the AMR Action Fund with several major partners, and it was based on public health priorities, including over 20 pharmaceutical companies, philanthropies, Wellcome Trust, and Novo Nordisk Fonden, and the European Investment Bank with a pledge of 1 billion, hoping to produce 2 to 4 novel antimicrobial treatments or antibacterial treatments. And by the way, the definition of novel is included in our pipeline document, so you can also see what is meant by novel antibacterial. Again,
2 minutes, please.
this is my last slide. I'm done. So the last slide is just to show you how the WHO, after the ICG report, reinitiated the work with the two major agencies, OIE and FAO. And this is, again, you can find this online, the Multi-Partner Trust Fund document, as well as the tripartite work plan, working very closely together to make sure that the best of human health is preserved through addressing this extremely challenging topic. So in summary, the emergence of and spread of AMR is a reality, and in the presence of COVID, it is definitely not slowing down. We need to preserve antimicrobials for the better of human health and to preserve modern medicine, and this work needs to be done at a collaborative level, and we need to achieve our goals together in order to slow the emergence of AMR. Thank you very much for your attention.
Thank you very much, Dr. Hanan, for this very enlightening and very comprehensive presentation. It's really exciting to see the response of the WHO on the AMR in the current light of the COVID-19 pandemic. Thank you so much. We are honored to have you here. I think I have not seen any question in the chat, so I think also in the sake of time, we might have to move on to the last speaker of this session. And it's my pleasure to introduce Dr. Jomana Musmar. Dr. Jomana Musmar, she is the Public Health Advisor at the Office of Infectious Diseases and HIV/AIDS Policy, and she is also the designated Federal Officer at the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, also known as PACCARB, at the US Department of Health and Human Services in the USA. Dr. Jomana, it's a great pleasure to welcome you here, and your presentation is about One Health for All, US strategies to collaborate and combat antibiotic resistance. The floor is yours. Thank you.
Thank you, Dr. Thomsen, and I just want to make sure that everyone can hear me, yeah?
Yes, we can hear you.
Okay, fantastic. A sincere thank you, and thanks to Dr. Najiba for inviting me to represent the Council and the Department of Health on this fantastic platform. And also it's an honor to follow Dr. Balkhy in terms of the presentation she gave, and also the transition to the policy world. So I know that there was a lot of talk on the clinical aspects, and I'm going to take you through the US response and the policies that we have in place, and also just the effort that we have comprehensively to combat antibiotic-resistant bacteria. As mentioned, I'm the designated federal officer for the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. We are a federal advisory committee, and we provide advice and recommendations to the Secretary of Health on all things related to AMR. Okay, and as I mentioned, this is me. I represent the Department of Health and their perspectives. So today I'll be discussing One Health, just elaborating just a slight bit more from what Dr. Balkhy has mentioned in its relation to antimicrobial resistance. You'll learn about the federal effort in the United States to combat resistance. I'll also describe the federal and non-federal collaborations that we have to gain as much insight into the policy that's needed to combat AMR. Explain of our own internal US National Action Plan on CARB, or combating antibiotic bacteria, and identify the federal resources for you all to use on AMR and highlight ways to get involved yourself. So just a little bit about the silent tsunami that was previously mentioned to describe AMR. As you all know, antibiotics are important tools for addressing bacterial infections in humans and animals, and save untold millions of lives each year. However, their usefulness is threatened by the development of these resistant strains of bacteria and fungi, not to forget, which can cause untreatable infections. Preventing these infections in the first place is a foundational step towards combating antibiotic resistance. And as you know, every infection prevented is one less instance of antibiotic use, and using fewer antibiotics significantly reduces the risk of resistant infections. Hence the intense conversation of stewardship. We now know that more than 2.8 million illnesses and 35,000 deaths result from resistant infections each year just here in the United States. And the healthcare costs are commensurately extreme. And according to the 2019 CDC Threat Report on AMR, efforts to reduce the effects of antibiotic resistance are working. From 2012 to 2017, the overall number of US deaths from antibiotic resistant infections fell by 18%, and the number of US deaths from resistant infections in hospitals fell by 30% as a result of efforts to prevent these infections and control their speed. However, resistance continues to harm too many Americans here in the US, and worrisome trends are emerging, including the discovery of new resistant pathogens such as Candida auris, and an increase in resistant Neisseria gonorrhea infections. These microbial pathogens continually evolve new ways to evade the drugs that are designed to kill them. And unfortunately, our pipeline is dire, as Dr. Balkhy showed in the last slide. So just a little bit about One Health. What is One Health? We know that germs can move between hospitals and communities through people. And within communities, these germs can spread between people, the environment, and animals. Germs continue to spread and develop. Resistance and progress may be undermined by some community-associated infections that are on the rise. One Health is an approach that recognizes that the health of people is closely connected to the health of animals and our shared environment. For example, issues include zoonotic diseases, antimicrobial resistance, food safety and food security, vector-borne diseases, and environmental contamination. As such, the US government effort towards combating antibiotic resistance takes a true One Health approach, recognizing this interconnectedness and thus promoting collaboration and communication among the different agencies and non-federal stakeholders on the critical issue of AMR. So just to give you a little bit about the government response, the US government is responding to resistance with a comprehensive and coordinated suite of actions implemented by a diverse set of agencies using a One Health approach. While federal efforts to address resistant infections go back decades, the current form of this response was instigated largely by a 2013 CDC report on antibiotic-resistant threats in the US and a report issued by the President's Council of Advisors on Science and Technology. So then in 2014, an executive order brought the US government effort together under one umbrella with structure and strategy to guide our efforts. A CARB task force, which is the purely federal entity composed of mainly agencies across the One Health spectrum, including the Department of Education, Department of Agriculture, EPA, the State Department, and others, was formed to help create a national action plan, which they would further implement. And then the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, which is the council that I manage, was also formed to help provide advice and recommendations and facilitate any challenges that the CARB task force may be facing in implementation of the goals and objectives in the National Action Plan. It's a truly collaborative effort, and that way we gain outside stakeholder input and help inform the federal government in its efforts to implement many of these objectives. So just a little bit about the council that I manage, the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. We are political, we are a bipartisan entity, and we have, when we tackle antibiotic resistance issues through a truly One Health spectrum by virtue of our membership, we have both human health and animal health subject matter experts that compose the council. We are, as I mentioned, we were issued by executive order, but another authority included us just recently last year under the Pandemic and All Hazards Preparedness and Advancing Innovation Act of 2019. And the significance of that is the fact that this papaya, I like to call it, is a largely biodefense-centric and public health security-centric piece of legislation. So it puts AMR in a biodefense context, not just public health, and it also puts AMR in a public health security context, elevating it in agendas and elevating it on the Hill here in the United States. Our mission is to advise the Secretary of Health and Human Services, and we have particular duties that are mentioned here. The main scope of our work revolves around the effectiveness of antibiotics, the development of diagnostics and innovative solutions, including alternatives to antibiotics and antibiotic stewardship, surveillance of antibiotic-resistant infections, education of healthcare providers and the public, methods to reduce the transmission of infection, and coordination and international efforts to improve US capabilities. And we do this from a truly One Health approach by trying our best to address the human health, the animal health, and the environmental components overall. So just a little bit about our reports thus far. So as I mentioned, we are advisory committee. So when we get asked the question by the secretary or a task comes up or our chair even identifies a particular area that they want to focus on, we hold a series of public meetings that everyone can join because they are public, and that's the value of a federal advisory committee, is the transparency process and the ability of the public to collaborate and provide their input to the council members for consideration. So we have a series of reports that we've issued since our inception in 2015. But most notably, I'll speak a little bit about was our Enhancing Infection Prevention and Antibiotic Stewardship report, our incentives report, and also, most importantly, the input that we've provided in for consideration into the next iteration of the federal government's National Action Plan on combating antibiotic-resistant bacteria. So just a little bit about the 2017 report, because the issue of incentives and ensuring that we have a pipeline of all antibiotics and even alternatives is crucial, as Dr. Balkhy mentioned. Our second report issued recommendations for incentivizing the development of vaccines, diagnostics, and therapeutics to combat antibiotic resistance. It identified barriers in the AMR product and diagnostic development process, and the recommendations included ways to incentivize and accelerate new products that maximize the return of investment and encourage stewardship by focusing on economic, research and development, regulatory and behavioral issues. And the council took feedback from a wide variety of associations and organizations that have already tackled this issue, including the Duke University's Margolis Center for Health Policy, Wellcome Trust, which has been an active participant in the AMR Action Fund, as you saw, Drive AB, which is the Driving Reinvestment in Research and Development and Resource Responsible Antibiotic Use Consortium, the Pew Charitable Trust, and the Infectious Diseases Society of America, among others. The next report in 2018 was on key strategies to enhance infection prevention and antibiotic stewardship. This also included recommendations, but this one was focused on human and animal health as well. So if you take a look at the diagram that you see, we provide 7 recommendations to improve infection prevention and antibiotic stewardship, where they do stand alone. However, when implemented together, they provide a holistic approach to stewardship and IPC. The intent of the diagram is to portray that the effective and efficient implementation of infection prevention and antibiotic stewardship practices in a wide variety of settings for both human and animal would ultimately drive the growth and maintenance of a workforce with robust education and competencies at multiple levels to carry out the needed work to combat resistant infections and promote stewardship. So the whole purpose of the gears that you see here is that one moves the other, and once they all move together, you have a very robust IPC and antibiotic stewardship program. So just to close out a little bit about the council again, we meet 2 to 3 times a year publicly. We used to do that in person, but now we're fully virtual. So the access to our meetings is even more so via these virtual platforms. You can visit us at hhs.gov/PACARB if you want to look a little bit more into the reports that I just mentioned. All of our meetings are archived. All of the PowerPoint presentations are archived. We have tackled everything from microbiome and gut health in bees on the agricultural side, crop health and for apple trees, and also, of course, the clinical components of antibiotic resistance in human health and also for food animals as well. There's a wide variety, there's a ton of resources, so please do visit us and look at our past meetings and check those out. So transitioning from the Federal Advisory Committee process, where we have external stakeholders that are serving as voting members on this council, I'll now describe a little bit of the Federal CARB Task Force, which is a purely federal entity and mainly responsible for the development of the next iterations of the National Action Plan for the United States to combat resistance, and also to implement all of the directives that are in there. So in parallel to the council's operation, the CARB Task Force pulls together the relevant agencies across the One Health spectrum to promote collaboration and communication. These are the agencies in front of you that you see on the CARB Task Force, and it's co-chaired by the Department of Defense, Department of Agriculture, with the Department of Health and Human Services at the helm. The Office of the Assistant Secretary for Planning and Evaluation, or ASPE, within the Office of the Secretary of Health and Human Services, serves as the federal coordinator for the task force. The PACARB, which is the Federal Advisory Committee that I manage, is coordinated by the Office of the Assistant Secretary for Health, or OASH, which is a sister division within the Office of the Secretary. I know it's a lot of offices. There are many, many offices within HHS, and we all collaborate and coordinate very, very closely to break down silos and ensure that we're all receiving and sending the same message. So a little bit about the National Action Plan for Combating Antibiotic-Resistant Bacteria that was developed from the CARB Task Force as a result of the strategy that was set forth vis-a-vis the executive order in 2014. So the 2015 National Action Plan, as I mentioned, set in motion the nation's coordinated federal response to antibiotic resistance, one of the, of course, the greatest global health threats of our time. The National Strategy for CARB is the foundational document that guides the task force's work, and it's organized around these 5 goals that you see in front of you. The 5 goals are focused on infection prevention and stewardship, surveillance, diagnostics, treatments, plus the international collaboration on CARB research and development. So major progress has been made in the United States since the first National Action Plan was launched in 2015. And just to pick some highlights, the US government worked with partners on all of these achievements, including the Antibiotic Resistance Lab Network, CARB-AB, and they pursued alternatives for antibiotics in agriculture and obtained hundreds of commitments to global action through a CDC-sponsored 2018 AMR challenge that was also co-sponsored by the National Institutes of Health. The task force, the CARB task force, has reported on these advances each year, and they will be publishing a comprehensive summary of the progress in the forthcoming Year 5 report, due to be released, I believe, early next year. So knowing that 2020 was not the end of the story, and that the National Action Plan was a foundation to build upon, in the fall of 2018, the CARB task force pulled together 125 experts crossing the One Health spectrum and drew from the PACARB's report on public input. So as I mentioned, we provided input as priorities for the next iteration of the National Action Plan, and the CARB task force took that into consideration in addition to a wide net of research that they cast to other stakeholders as well, also within the federal government, to gain as much insight as to the changing landscape of AMR after the first 5 years that happened, to issue their next iteration, which is actually due to be released today in 2 hours. So this is an excellent example of where a federal advisory committee composed of non-federal stakeholders and subject matter experts provides input into the federal government for them to actually insert some of those recommendations into a federal document. So the PACARB report that I mentioned into the National Action Plan was tasked by the Secretary in 2018 to identify these priority areas. And this is just a snapshot of the infographic that we have in our report. Overall, the Council's input supported the continued efforts of the original National Action Plan and recommended additional attention to the rise of drug-resistant fungi, AMR in the environment, especially sewage and wastewater, and U.S. global leadership in combating AMR across all 5 goals of the National Action Plan. So since the first plan was launched, the U.S. government and partners have addressed the spread. Just to give you a few highlights of the great things that have happened since then, that the federal government has achieved. Developing and implementing effective strategies to prevent infections, including a program that resulted in 54% fewer catheter-associated urinary tract infections, or CAUTIs, in more than 400 long-term care facilities. The U.S. government also supported antibiotic stewardship programs to ensure the appropriate use of antibiotics in diverse healthcare settings, with nearly 90% of our U.S. acute care hospitals meeting all of the CDC's core elements of antibiotic stewardship. And then just another one briefly, the U.S. also obtained nearly 350 commitments from partners across 31 countries for the AMR challenge that I had mentioned previously, led by the CDC, one of the most ambitious global initiatives to date. And the U.S. government led global action from a broad range of sectors and stakeholders to combat antibiotic resistance. And I also should mention that our Office of Global Affairs also leads this effort as well.
2 minutes, please.
Thank you. So the resulting CARB National Action Plan for 2020 to 2025 presents a set of coordinated strategic actions to change the trajectory of antibiotic resistance in the next 5 years. The plan maintains the 5 goals and adds new elements. And it's important to know that all the objectives in the new plan build on existing programs and policies, while other objectives reflect new activities. This new plan continues to reflect One Health, recognizing the interconnectedness between the health of people, animals, plants, and the environment, and to prioritize infection prevention and control, and the appropriate use of antibiotics, and the support, of course, for innovative products. Combating antibiotic-resistant bacteria remains a priority for the U.S. government, even amidst the current COVID-19 pandemic. And as we've seen, the response to COVID-19, surveillance, detection and containment, and having the right drug at the right time are key to addressing the spread of infections and treating disease. The plan will be released by noon today, which is 8 p.m. UAE time. So for the next slide, briefly, I have references here for your information. A lot of the information that I already had in the slides previously had some, but if you go to the very last link here, this will include the most up-to-date report, and it'll also be included on our website as well, hhs.gov/PACAR. This is how to reach us. You can email us at carb@hhs.gov and please send us your insight. We're obligated to share it with our council members. Send us your comments, and thank you so much for including us. I'm done.
Thank you very much, Dr. Jomana. That was very interesting and really enlightening. Thank you so much for giving us the US perspective. And I think we would then hand over to session number 3, where we have 4 more exciting presentations coming up. Thank you all for your interest, and I'm handing over to Dr. Ashraf for moderating the last session. Thank you.
Thank you, Dr. Jans. I think we just behind our time with only a few minutes. So thank you very much for all the speakers. Give me a great pleasure to introduce our next speaker. We have seen a question in the chat or in the QA boxes about the Candida auris. So I just tell the person who posted that question that now you will have all the time to listen to Dr. Meghan Lyman. She's got all the way from the CDC, Atlanta, Georgia. She is from the Mycotic Disease Branch, Division of Foodborne, Waterborne, and Environmental Disease. And she will be giving us a presentation about epidemiology and infection control of Candida auris. The floor is yours, Dr. Meghan.
Thanks so much for having me. I spent a lot of time at the CDC working on the new Candida on the block, Candida auris, and I'm planning to share with you what we've learned about it and our experience here in the US trying to contain the spread. So for those of you who haven't heard much about Candida auris, it was identified by CDC in our 2019 threats report as an urgent threat requiring aggressive action. But why are we so concerned about it? Candida auris does have some unique characteristics that are different compared to other Candida species. For example, it colonizes patients' skin and can lead to invasive infections. It's often more resistant to antifungals and acts more like a resistant bacteria. And it contaminates the patient's environment and can spread in healthcare settings. Since being reported in Japan in 2009, it's spread worldwide and it's been reported in more than 35 countries, including UAE and the United States. And in some of these countries, like South Africa, it's become one of the top causes of candidemia or Candida bloodstream infections. And after it was first detected here in the US in 2016, CDC issued a clinical alert, and as you can see, the number of cases has grown substantially. As of June, there had been over 1,200 clinical cases in which specimens were collected as part of routine clinical care, and over 2,400 screening cases in which patients were specifically swabbed to screen them for colonization. And these cases have been reported from various states across the US, but some areas have been more affected than others, especially New York, New Jersey, Chicago, and the strains in these locations are not all the same. The cases also represent 4 different clades and possibly a 5th clade, but certain clades predominate in certain areas of the US. Whole genome sequencing has demonstrated that isolates in different parts of the US are similar to isolates in these other parts of the world, but this isn't necessarily reflective of positive patients actually traveling to these countries. And as I briefly mentioned earlier, Candida auris is more resistant to antifungals than other Candida species. For example, it has about 80% azole resistance compared to Candida glabrata, which has only 8% azole resistance. And pan-resistant isolates with resistance to all 3 clades have been reported from several countries, and there have been 4 pan-resistant clinical cases reported here in the US since 2019. And these cases were unrelated and weren't transmitted between these patients, and instead they developed resistance on treatment. While there have been cases introduced from other countries, most cases at this point in the US are the result of local transmission and don't have direct links to healthcare abroad. So as I mentioned, whole genome sequencing shows these connections to clades in other countries, but at this point now there's more local transmission than importation or introduction from abroad. Most patients with Candida auris in the US are typically very sick and often have tracheostomies, are ventilator dependent, colonized with other multi-drug resistant organisms, have recently received antibiotics and antifungals. And many of the cases and transmission we see are in long-term care facilities with patients who need a lot of medical care and are not suitable for hospitals or for being discharged home. We have not routinely seen much transmission in hospitals, perhaps because they have single rooms or better infection control. But more recently, we've seen outbreaks in hospitals as a result of poor PPE use in COVID units, where they may wear the same gown for multiple patients. But fortunately, it doesn't seem to affect the general public or healthy individuals. There have been a few studies done that showed healthcare personnel do not get colonized, and we have not recommended to screen staff. As I mentioned earlier, Candida auris colonizes the skin, which is why we recommend screening by swabbing the bilateral axilla groin, but other body sites like nares can be colonized as well. Colonization can persist for many months and perhaps indefinitely for some patients in healthcare settings. And unfortunately, there aren't any recommended decolonization methods at this time. But this long colonization is obviously troublesome because it increases the risk of transmission to others and increases the risk of invasive infection for the patient. This is data from Chicago, which demonstrates how long patients remain colonized for and how swabs are intermittently positive and negative. So we don't recommend rescreening patients to evaluate for clearance, especially those with no change in their clinical status or change in their environment. There's some hope that patients who have clinical improvement and may go home are more mobile, have regular hygiene, may be more likely to clear their colonization, but there is not a lot of evidence about that yet. We don't think Candida auris is necessarily more virulent or pathogenic than other species, but colonization with Candida auris is relevant because we have found that it leads to invasive infections in 5 to 10% of colonized individuals. And among these patients with invasive infections, there's about a 40% all-cause mortality in 30 days. But this is not attributable mortality and doesn't take into account how sick the patients are at baseline. Colonized individuals contaminate their environment and can spread Candida auris to others, but we found that the risk of transmission is not just limited to roommates. All patients on the ward are at risk. You can see this is a map of a nursing home ward in Chicago with ventilated patients. And they started with one patient positive for Candida auris there in the bottom in the solid purple circle. And when they checked 10 months later, Candida auris had spread to patients all over the unit, so that almost half of the patients on the floor became colonized. And you can see there are some rooms that have patients that screen positive and a patient that screen negative. So the risk was really, distributed equally to patients across the ward. And they weren't just colonized with Candida auris, but lots of other multi-drug resistant organisms. You can see all the colors of combinations of MDROs. And this makes cohorting very challenging. One thing that probably contributes to this spread is that Candida auris persists not just on people, but in the environment and can survive longer than a month on surfaces. Some common disinfectants, particularly those with quaternary ammonium compounds, are not effective against C. auris. Shared or mobile equipment can also become contaminated and has been implicated in multiple outbreaks, which is likely one reason that Candida auris can spread to any patient on the ward, not just roommates. So early detection is the key to controlling spread. The earlier a case is identified, the earlier you can implement control measures like transmission-based precautions, interfacility communication for patient transfers, enhanced lab surveillance, or region-wide alerts. But identification has been challenging for several reasons. Candida auris is often misidentified by various diagnostic methods as other Candida species like Candida hemolonii or Duobus hemolonii. But this is getting better with recent database updates, improved access to MALDI-TOF, in general increased awareness, and the ability to confirm at reference in public health labs. Another challenge is that yeast are often not identified to the species level, especially for non-sterile sites like urine. Only about 50% of clinical cases are from blood, so not identifying the species of Candida from other sites like sputum or urine may result in missing a lot of colonized cases. Even if these aren't clinically relevant because maybe you wouldn't treat them, they would be relevant from a public health perspective. And finally, cases of colonization can be missed if screening isn't being done. But there's some strategies that we have used to improve early identification. As I mentioned, doing species identification of Candida from any body site, not just invasive specimens, will help and is a good way to more passively keep an eye on things, especially for facilities or labs that may not have had cases, but may be high risk for having a case. So in one county that had not had any cases, a lab that was serving long-term care facilities decided to start species identification of yeast from urine specimens. And they found their first urine positive for Candida auris months earlier than the first clinical specimen. And this obviously allowed for earlier implementation of infection control precautions and prompted more widespread screening that identified more than 100 colonized cases at other long-term care facilities. Colonization screening is another more proactive strategy. CDC recommends at a minimum screening close healthcare contacts of patients infected or colonized. And again, that doesn't mean just roommates. They also recommend screening patients who have had an overnight stay in a healthcare facility outside the US in the previous 1 year, especially if they came from a country with documented C. auris cases, and especially for those who are infected or colonized with another multi-drug resistant organism. And I know of at least one case where there was a US patient that had a carbapenemase producing organism and a hospitalization in Kenya that was found to be colonized for Candida auris. Some places are choosing to do additional screening, like point prevalence surveys in high-risk facilities, like nursing homes, as part of a larger containment strategy. And these high-risk facilities are ones that have had cases or ones that haven't yet, but are likely to have cases. Like I mentioned, nursing homes or facilities in areas that are known to have a high prevalence of Candida auris. And during these point prevalence surveys, they'll swab everyone in the facility or everyone in the high risk ward, like a ventilator ward, all at the same time. And one state conducted periodic point prevalence surveys at one nursing home near a high prevalence area, even though they had not had any cases. And they detected 4 cases of Candida auris colonization. And this is a result of patients being moved between the high prevalence area and other bordering areas. And then finally, admission screening is another strategy to identify cases and implement appropriate infection control precautions as early as possible before they have the opportunity for spread. It's also a good chance to identify where cases are coming from, which may be potential reservoirs of transmission. But admission screening is being done differently in different places and really needs to be based on the local epidemiology. So taking into account the characteristics of cases and characteristics of facilities that have had cases in the area. Unfortunately, screening in some areas here in the US has gone down during COVID, which makes us concerned that cases aren't being identified and that there's undetected spread. So for infection control, what can be done to prevent spread? The infection control measures for C. auris are really just the basics. So for hand hygiene, alcohol-based hand rub is effective and preferred over soap and water, except when hands are visibly soiled. Transmission-based precautions, contact precautions, but as I mentioned, we've seen transmission during the COVID response related to changes in PPE practices and PPE conservation strategies like extended gown use for multiple patients. And these conservation strategies are sometimes necessary, but we're really trying to emphasize to facilities that they should only be implemented as required by supply availability. In other words, don't use crisis strategies when you have supplies available and conventional strategies are possible. Environmental cleaning and disinfection is really important, and it's important to make sure that cleaning and disinfection is done effectively. So making sure that staff are adequately trained, it's clear which staff are responsible for cleaning what items or surfaces, making sure cleaning and disinfection products are easily accessible, and that shared medical equipment is cleaned and disinfected before being used on another patient, because this shared equipment is a common source of transmission. And many local health departments will do infection control assessments after a facility has transmission to make sure that IPC practices are being implemented effectively. And sometimes they'll do assessments in facilities that haven't yet had a case, but are high risk to reduce any opportunity for transmission in the event that there's an introduction. And as I mentioned, there are some products, including quaternary ammonium compounds, that are often used in healthcare settings that don't kill Candida auris. So we recommend that facilities use a product proven to be effective against Candida auris. Here in the US, we have a list that have an EPA approval. And the number of these products is growing, and there are some products that just recently received this emergency exemption for use against Candida auris and are listed on our website. And all of these are effective against COVID. But if these products aren't available, you can use a List K product against, effective against C. diff, but not all of these are effective against COVID, so you would need to check. It's also important that a patient's Candida auris status is communicated when they are transferred between facilities so that precautions can be implemented. And we found that this is often a gap and has been the source of transmission numerous times. So CDC has some resources like this interfacility infection control transfer form that can help with Candida auris and other multi-drug resistant or communicable pathogens. So in summary, Candida auris is a new bug, but using a lot of old tricks. It's resistant, it's easily transmissible, and similar to other resistant bacteria. So we have learned a lot and we're still learning, but we do know how to control the spread of bacteria that behave similarly. So we're using a lot of those strategies. So thank you.
And now we'll move to the second speaker. Give me a great pleasure to invite my friend, Dr. Shafi Mohammed. He is the director of the infection control program in Cleveland Clinic, Abu Dhabi, and he is the co-chair of the infection control committee. He will talk about infection control issues in the intensive care unit. Dr. Shafi, the floor is yours.
Good evening, everybody. It gives me an absolute pleasure to join virtually this conference. I want to thank my friends and colleagues, Dr. Ashraf, Dr. Najiba, Dr. Jens, for putting together this conference. So thank you all. I'm going to talk about the infection prevention in the ICU environment. So let me begin my talk by explaining how complex the process of preventing infection in ICU patients. So, you know, if you take nosocomial infection as a whole, but 2/3 of nosocomial infections occur in ICU patients. And what makes these patients more vulnerable from getting this kind of infection is simply because they have compromised host defenses, you know, following major surgeries. These are the kind of patients that have a lot of insertions of plastic devices, such as Foley catheters, peripheral IVs, you know, PEG tubes, central line devices, etc. Majority of these patients tend to be on antimicrobials, either for therapeutic use or for prophylaxis use, which put them at risk of developing multi-drug resistance, colonization, or infections. They tend to be malnourished, and the majority tend to have underlying comorbidities. So these are the main factors making an ICU patients more at risk of developing infection and adding the complexity of preventing infection in this kind of settings. And you know, obviously when these infections occur, you know, they add the risk of mortality. There's a lot of studies out there that shows patients in ICU, when they have infection, they are at higher risk of dying than their counterparts outside ICU. It complicates underlying comorbidities, adding unnecessary lengths of day hospital stay, adding cost, and then adding the risk of developing multi-drug resistant pathogens. So for my talk, my main focus is on epidemiology of nosocomial infections in ICU, the surveillance, what do we monitor in ICU patients, device-related infections and how we prevent them in ICU, procedure-related infections and how we prevent them in ICU. And then finally, I will touch base on epidemiological significant pathogens in the ICU environment and what are we doing to prevent them. So it's surveillance of nosocomial infections and processes is an integral component of an infection control program in ICU environment. Surveillance is not purely a collection of data. It's a process for collecting data, making sense of the data for the purpose of taking action to improve a patient's care. So basically, you know, it's a process of monitoring what is going on in the ICU environment so that you can take actions to improve the patient's care. Next slide, please. So in terms of surveillance, surveillance mainly divided into two main parts. So there is a surveillance for process measures. So this is what the day-to-day activities happening in ICU environment to prevent the outcome, which are the nosocomial infections. So the surveillance for outcome measure, this involves hand hygiene observations, the compliance with the CAUDI bundle, CLAFSI bundle, the VAB bundle, the surgical care improvement pathway bundle for prevention of surgical site infection, and then the compliance for multi-drug resistance of organism screening protocols. And in terms of the outcome measures, the surveillance for outcome measures in ICU involves outcomes such as urinary tract infection with or without catheter, bloodstream infection with or without intravascular devices such as central lines or peripheral lines, pneumonia with and without ventilators, Clostridium difficile infection, the multi-drug resistance infections, the colonization, as well as surgical site infection. So these are the main key performance indicators that the infection preventionists and those who work in bedside tend to look at in ICU environment. Next slide, please. So now let's have a look at the, some of the key infection prevention strategies / interventions that are being used in a day-to-day basis in ICU. The very first and most important intervention is hand hygiene. So hand hygiene is the cornerstone of all the efforts for prevention and control of infection. According to the World Health Organization, disappointingly, hand hygiene compliance globally still remains around 40%. Most of the hospitals recently, because of the pandemic, we've seen a bump in hand hygiene compliance, basically because of the fear of the pandemic. Healthcare workers have started have what we call a pandemic-induced behavior. So a lot of people are now cleaning their hands, which has helped in improving hand hygiene. But relatively speaking, compliance remains poor around the world. Let me share a quick story that shows the importance of hand hygiene for prevention of nosocomial infections. In 1847, in Vienna Hospital in Austria, there were two clinics whereby the expectant mothers in one of the clinics were attended by the junior doctors, and another clinic where expectant mothers were attended by the midwives. The clinic that had junior doctors attending expectant mothers had higher mortality from puerperal fever. What was interesting was that no one had a clue what was the cause for higher mortality in this clinic where the expectant mother were attended by the junior doctors. Ignaz Semmelweis, was an Hungarian physician, or the OB-GYN guy who worked in this hospital, and he was disturbed by these observations. And it was up until the death of his close friend, who was a pathologist, Dr. Kolechka, who accidentally inoculated himself while performing an autopsy from a patient who died from puerperal fever. Several days later, Kolechka developed signs and symptoms mimicking the patient who were dying from puerperal fever. It was at this point that Ignaz Semmelweis had an eureka moment, and he put on the hypothesis that it could be the cadaveric particles that are seen in the autopsies that are responsible for causing this death in this population of women. So as a result of the intervention, he implemented chlorinated lime and asked all the junior doctors to clean their hands with chlorinated lime prior to attending these women. And within 3 weeks of this intervention, the mortality rate in 1847 in Vienna Hospital in Austria dramatically declined from 14% to 2%. This is a story that shows how important hand hygiene is in saving lives in the healthcare environment. Sepsis are one of those nosocomial infections that are very challenging to monitor and to prevent in the ICU environment. The sources of infection in the patient who was centralized, the catheter hubs, contaminated catheter hubs, the insertion site which may be contaminated, the skin of the patient, very rarely the contaminated infusets, and occasionally infection from a distant location. The first 10 days when the catheter is inserted, we tend to see colonization mainly from the organism coming from the patient's own skin. After 10 days, the sources of infections or pathogens tend to come from intraluminal sources, in particular, the catheter hubs and infections from the distant location. The point here is not all catheter colonization leads to infection. However, the catheter colonization is a predisposing risk factor for developing an infection in the patient who was a central line. So prevention of CLABSI is basically targeted at two main areas, at the time of insertion and the time of maintenance. And infections from CLABSI can be easily prevented through adherence and implementation of an evidence-based practice during the time of insertion, as well as evidence-based practice at the time of maintenance of the line, as soon as the line has gone in. The most important intervention, either at the time of insertion or maintenance, is hand hygiene, followed by the early removal of the central line. Because for every day that the line is in place, it adds a risk of developing CLABSI to that particular patient. Cloudies are another nightmare in ICU environments. In any hospital, about 1/3 of patients have urinary catheters, and about 2/3 of those urinary catheters tend to be in ICU environments. Over 80% of UTIs in hospitalized patients are caused by faulty catheters. For every single day a fault is in situ, there's about 3 to 5% risk of developing bacteria in the urine. So mathematically speaking, by day 20, if you send a urine culture from any patient who was a faulty catheter, you're more likely to find bacteria in the urine. However, the presence of bacteria does not mean that the patient has an infection. However, bacteria in the urine is a significant risk factor for developing a urine. So the key message here, the earlier you remove the catheter, the lower the risk of developing cavity. Equally, the prevention for cavities should be focused in two main areas: at the time of insertion and at the time of maintenance. However, the most effective way is to reduce the duration of catheter in order to minimize the risk of developing bacteria in the urine and subsequently preventing cavity from a catheterized patients. VAP or VAP or VAE is another important nosocomial infection in the ICU patients. The sources for microorganism in the patient with a ventilator from exogenous point of view tend to be the contaminated hands of a healthcare worker, the contaminated ventilator circuit, and the biofilm that tend to form in the ET tubes. Endogenous wise, the sources of microorganisms tend to be the impaired nasopharynx, which fail to clear the nasal colonization, the colonized oropharynx and gastric fluid pool along the tube in the neonate patients, and then the colonized tracheal secretion. So these are the important sources for endogenous as well as exogenous pathogenesis in terms of developing VAP or VAEs. Prevention of VAP, similar to CLABSI and cavities, these infections can be prevented by strictly adhering to the prevention bundles. So head of bed elevation 30 degrees, the daily sedation vacation, and assessment of readiness to extubate, and the peptic ulcer disease prophylaxis, as well as the DVT prophylaxis, and most importantly, daily oral care with chlorhexidine every 6 hours. Surgical site infections is another category of infection that we tend to see in ICU environments. The prevention of surgical site infections requires a collaboration with clinicians working outside ICU, especially those working in the OR or peri-op areas. Patients are required to receive antibiotics within 1 hour prior to the surgical site incision. The hospital has to strictly adhere with the local antibiotics usage for prophylaxis, depending on the type of surgery. Discontinuation of antibiotics within 24 hours in order to minimize the risk of developing multiple resistant pathogens. Appropriate surgical hair removal with clippers rather than using razors. Either removal for the catheter on day 1 or day 2. And then temperature management. So maintaining normothermia during surgery and after surgery is very, very important, especially in the ICU environment. And epidemiological significant pathogens, we tend to see a lot of these in ICU. Members of gram-positive, MRSA and VRE continue to pose threats to patients in ICU. And then the more stubborn ones, as we all know, the gram-negative bacteria, in particular, those from Enterobacteriaceae family, such as those which have resistance to carbapenem, so CRAs and CPEs. E. coli that are producers for extended spectrum beta-lactamase, multi-drug resistance, multi-drug resistant Acinetobacter, as well as Pseudomonas, C. diff because of the antibiotic exposure in the ICU environment. And then as Dr. Meghan presented, the Candida species, which is an important fungi now around the world. The spread of multi-drug resistance in the ICU environment tends to happen as a result of failures in hand hygiene practice, transfer of patients within the facility and outside facilities, so receiving and transporting patients outside facilities, contaminated equipment and environment, and the colonized hands of healthcare workers. Selective pressure for overused antibiotics in ICU environment, either for prophylaxis or for therapeutic reason. And then bacterial genetic mutations, which we tend to see, and a lot's happening, especially amongst the bacteria from Enterobacteriaceae family. Antibiotic stewardship, this is another important intervention. I'm pretty sure previous speakers have spoken greatly about how effective antimicrobial stewardship is for preventing of multi-drug resistance infections. Antimicrobial stewardship program, if implemented effectively and efficiently, it has shown to reduce antibiotic use by up to 40%. It reduces the risk of development of multi-drug resistant infections. It reduces length of stay and improves patient safety. So this is an important intervention to be utilized in all hospitals, especially in the ICU environment where we see overusage of antibiotics in comparison to a setting outside ICU. Multi-drug resistance screening in ICU environment, this is a topic of debate. There are some people thinking it is effective, some think not effective. As Dr. Meghan say, this is the screening intervention. It only detects the tip of an iceberg. Every time when you detect a patient with a certain infection or colonization, MDRO, there are behind that patient, there are tons of infection that go undetected. Those who are in favor of screening for MDRO in ICU environment, they argue that since colonization precedes infection, so it's better to understand the proportion of your patients that are colonized so that you can take appropriate measures, such as decolonization, for instance, in the case of MRSA, or to initiate isolation precautions so that you can minimize the risk of spreading of MDRO infections to other patients in the ICU environment. Other measures to consider beside the one that we have explained, staffing ratio is very, very important. There's a lot of literature to support that poor staffing level greatly contributes to infections especially amongst nurses, when you have shortage of nurses, people tend to take corner, especially around poor compliance with hand hygiene, and then the poor compliance with following the bundles for CLABSI and cavities. Healthcare worker vaccination, for instance, influenza vaccine, we're now in the flu season, so it's very, very important for healthcare workers to get vaccinated in order to minimize the risk of spread of influenza to the vulnerable patients in ICU environment. Improving nutrition in ICU environment is very, very important. The use of probiotics to decrease C. difficile infections, topic of debate, literature, there's a lot of evidence in literature there to support the use of probiotics to decrease C. diff infection, especially in the geriatric population. And then there's literature that goes against it. The use of silver-coated urinary catheter to decrease cavities, as well as CLABSI, has also been shown to be an important intervention for preventing device-related infections. But in conclusion, guys, not all infections are preventable. However, for the infections that are preventable, we should do all the efforts to implement the culture of zero harm for all avoidable infection. It is not cool to say, in our unit or in our hospital, we only have few infections, i.e. only one infection, because one is too many. Behind number one, there is a human being like yourself and I who has been harmed while receiving care in our facilities. So thank you very much, and I welcome questions. Thank you.
Thank you very much, Dr. Shafi, for this illustrative presentation. And I think we are running out of time, so we'll just move directly to the next presentation. Give me a great pleasure to introduce our next speaker, Dr. Maged Al-Shamrani. He is the Executive Director of the Infection Prevention and Control Program in the Ministry of National Guard Health Affairs, King Abdulaziz Medical City in Riyadh, Saudi Arabia. He's, of course, a consultant adult infectious disease. He will talk to us about lessons learned in the COVID crisis using the antibiotics. And I think it will be a very interesting topic. Dr. Maged?
Okay, assalamu alaikum. I would like first to thank you all for giving me this opportunity. And it was a very interesting day, actually. A lot of, interesting topics enriched, this very important, subject of AMR, especially in this situation where we have pandemic and some of our essential activity to control, AMR and MDROs among our hospital or at the national or international level, actually went toward, controlling the pandemic of COVID-19. And this actually will lead us of uncertainty what will happen next. We know that AMR as a problem, it was there before COVID-19, it will stay for sure after COVID-19. COVID-19, hopefully soon it will go within that time. So generally speaking, my topic will be about COVID-19 and antibiotic-resistant and best practices. I will first, saying that I don't have anything to disclose. Afterward, I will go to my objectives. And my objective actually to look to the trends during COVID-19 of antimicrobial use. And also I would look to some literatures of antimicrobial use and overuse in COVID-19 patients. And I will share some of my insights, experiences from Ministry of National Guard Health Affairs. So in general, and this is, I'll go over it quickly, that AMR, it's a public health emergency. It's almost equal to, maybe more, from importance than COVID-19. And we know that people speculated we will have a lot of, death-related deaths in future years. And we don't know what will happen with COVID-19. This will make it worse, or it will ease it a little bit. So with speculation, this would make worse in the future. So it has high social and economic impact. It's more, from prevalent in our area, in the Asia and Africa. So we are at area of risk. The effect of COVID-19 on health system. We know that pandemics in general, it will increase the all cause of mortality around 2.3 folds in general. And when we look to the MDRO on COVID-19, we will notice that there are lots of factors that will make it, more challenging. So we know that we need to isolate COVID-19 patients, and we isolate them in the hospital. So this will occupy our isolation rooms, especially during pandemic and high influx of cases to the hospital. So we'll find ourselves all isolation rooms in our hospitals, and this is happening and these days. And it was a little bit intense during June and July and August. That actually dedicated totally to COVID-19 cases, and those with MDRO will be cohorted somewhere else. Also, we cohort a lot of COVID-19 cases together, and sometimes only because they are COVID-19, we don't look to other, factor or other, colonized organism, and this also will add to the problem. Also, some hospital, almost all the hospital actually, now they are doing MDR screening based on molecular basis. And during pandemic, COVID-19 pandemic, all cyclers in my hospital, at least that I know that we are using, even the one that we are dedicated for MRSA or MDRO, PCR screening, actually dedicated all for COVID-19 testing. And this slowed down and sometimes stopped up our surveillance protocol. There is increase of antibiotic prescribing rates, particularly broad spectrum ones, and also due to having more telemedicine, more prescribing over the phone or through online, there is a report of increased antimicrobial use on these spaces of outpatient setting. People, they start reporting that the COVID-19 may have a good impact on MDRO, and that because we increase general hygiene. We're talking about general hygienes, from social or physical distancing toward wearing PPEs and more hand hygiene than others. And I think, though that there are some reports and some studies, this will be temporary, hello? 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 Hello?
Your voice is clear, Dr. Magid.
Oh, I'm okay? Okay, good. Okay, I'm sorry. It just, it's like I'm losing you. Or, sorry, I'm here. So, generally speaking, that this will be a temporary, that these measures that we use now to, prevent spreading of COVID-19 is a temporary measures. It will, and it's not everywhere in the community, and sometimes there are a lot of breaches. So I don't think that the impact, even if it's for a while and being published, that it will decrease the MDROs in the community. But this will be a temporary, and it will not be sustainable. And we have to look to low-income and middle-income countries where they don't have, access to PPEs, and also they don't have access to hand washing and alcohol hand rub. And with these countries, also they have struggling with pandemic, COVID-19 pandemic, and also with the MDRO. So this, though that there are some literature saying and studies saying that it may have some important positive impact on MDRO or AMR, but this is not a sustainable thing. Then I'll go to look to some of the literature that I think it's very important to look at to understand the co-infection, to understand the bacterial burden during COVID-19 to the patient and also to the system. One of the things that I need you to consider first, that we dedicated some of the medications from literature point of view toward COVID-19 treatment as a primary drug, and some of them actually were antimicrobial. So we have azithromycin, some also literature saying ivermectins and other for HIV medication, which is lopinavir, ritonavir, or hydroxychloroquine, which is not antimicrobial. And these all studies actually being prescribed in trials and outside of the trials, and some people, they believe in them and start to prescribing them, and also as a community, people start to taking them for a while. With early, even non-benefit kind of reports from literatures. And that, of course, will end with some impact. Unfortunately, it's not measured right now, but later on, I think we will have some impact of overuse of these medications in the hospital, in the studies, and also in the populations or among community. The extent of co-infection with COVID-19 is not clear, and I will go over some also the study that looking to what are the possibility of having co-infections early on or late during COVID-19 infection. This is one of the early studies for 99 patients from Wuhan, and actually in this 99 patients, they look at trying to get some culture, either sputum or endotracheal aspirate, and they send it for early on upon admissions. And they found only one patient have fungal infection, which is Candida glabrata, and one patient only have some sort of multi-microbial kind of cultures with, like 2 or 3 organisms. The other were negative. But when we look to the number of antibiotics these patients actually receive, around 71% receive antibiotic, 15% of them were antifungal, 25% antibiotic given as a monotherapy, and 45 of this 99 patients actually they were having combination of therapy. And if you look to the antibiotic that we use in this study, we've been used in this study, cephalosporin, quinolones, and even broad spectrum antibiotic like carbapenem, ticagrelor, lenizid, and others. And duration of antibiotic were around 3 to 17 days, and this is median of 5 days. Another study looking to almost the same thing, and in this study, which is retrospective for clinical course and risk factor for mortality of adult inpatients. They around 191 COVID-19 patients, 54 died, and of the 54 patients, 53 were on antibiotic, and when they looked to the culture, only 27 had a secondary infection. So these two studies just give you a hint that Co-infection with bacteria was not one of the main reasons to lead to mortality, and there is also abuse of antibiotic in these, during COVID-19 pandemic. Another study, they're looking to VAB specifically, and they're looking to incidence of VAB, differences in secondary infections, and also the bacterial lung microbiome compositions on ventilated COVID-19 patients. They are using, molecular, kind of investigations to see the type of microbiome, and also they comparing between COVID-19 and non-COVID-19 cases, and in 3 ICUs, and it was a short study, almost like 1 month. What they found that the VAB rate was more in COVID-19 patients in general, but when we look to the composition of organism among COVID-19 and non-COVID-19 patients, actually there was no any differences between the composition of organism. Another very important meta-analysis we're looking to this issue of co-infection. This meta-analysis of 30 studies around almost like 4,000 patients, and mainly they are as an outcome looking to the proportion of patients with bacterial, fungal, or viral co-infections. Only 7% of hospitalized patients with COVID-19 they have co-infection, mainly toward the ICU patients and this for non-ICU patients, and very few cases, just in 3 studies, they actually found invasive fungal infection, which is mainly mold of Aspergillus type. The type of co-infection that they found from bacterial point of view, it was Mycoplasma pneumonia, the mainly bacteria, and it could be due to IgM secondary, which maybe inflated this number a little bit. Then Pseudomonas aeruginosa, then Haemophilus influenza. For viral co-infection, it's only in 3%. RSV influenza A, it was the most common or prevalent, viral infection. Though with this, few number, only 7% of co-infection and around just 3% of viral infections, in the study that reported antibiotic use, which is 17 out of the 30 study, around more than 90 patients, in 10 of them, actually receive antibiotics. So there are a lot of antibiotics being used, and from literatures and from study molecular and cultures, actually most of these patients, they have met only COVID-19, causing all their problem of pneumonia, and there is no much evidence, especially at early stage, just after intubations, or those who are non-critical, like in wards or outpatient setting. The co-infection is not there as we are thinking. And this is actually what they conclude. The COVID-19 co-infection with bacteria is not like what we used to see during influenza pandemics. It's much, much less, especially at early stage, as I said before. And there is no need to give a lot of antibiotic for COVID-19 patients, especially early on. And we have to monitor them carefully and closely. And we give antibiotic whenever it's clinically indicated, not only because COVID-19 and they have a pneumonia due to COVID-19. Broadcasting use, we used to in my hospital actually to have COVID-19 to guide our therapy and stewardship program. But unfortunately, there are a lot of evidence now that procalcitonin will increase due to COVID-19 infection itself. So this will make this very valuable test for our stewardship program not very beneficial. Maybe this is a little bit old, but I need just to give you the concept behind it. When it comes to direct antiviral therapy or antibiotic therapy, towards COVID-19, we have to go as per studies. Till now, there is nothing proof that we have to use it to treat COVID-19 as infection by itself, like antiviral or direct antiviral. No antibiotics and also no antiviral. And we have to follow international guidance with that. And we shouldn't start any patient or any drug unless we have it in a study or in a study, kind of clinical trial. When it comes to antimicrobials, the recommendation that for mild cases, we shouldn't give any antibiotic. For moderate cases, we have to follow the them closely and start antibiotic due to or based on clinical suspicion or cultures. For severe cases where we have severe COVID-19 patients with pneumonia and they are admitted to ICU, we have to follow do all the cultures and to follow the de-escalation approach. So we start broad spectrum antibiotic early on to clear guidance in your hospital based on your eco environment, the type of infection there in your hospital, and then you go quickly and de-escalate based on the culture result later on. Now I'll share with you the experience from National Guard Hospital in Riyadh. And what we did early on when we start, we have the problem with COVID-19. We start putting some policy, what kind of antibiotic we need to use for adult and for pediatric, and we teach people around the hospital, and also we publish it in all the channels inside the hospital so people they be familiar with. And also we did like a small group to manage all shortages in medications, either antibiotic or not, but we are focusing more on antibiotics because, as you know, that there will be some shortage with that early on. It was actually. Then we monitor all antibiotic with or drug with some significant towards direct treatment of antiviral of the COVID-19 virus itself. So we put some restriction on them, and also we put some method to monitor the prescribing behavior in the hospital. Unfortunately, this was a little bit not strengthened for outpatient setting, but at least in the hospital ICU it was well maintained. And also we tried to push to maintain the respective audit and feedback rounds in the ICU mainly. And our colleague Dr. Ashraf, we mentioned that earlier, that during COVID-19 and before COVID-19 even, we need a dedicated manpower for stewardship team, and also very important for prospective audit and feedback rounds. During COVID-19 pandemic, people were stretched. We have new ICUs, people went everywhere. So the dedicated people that we have usually to do this part, very important part of the stewardship program, we lost it for a while. And then we tried to push to have it again. Even we did it for a period of time as a virtual, just to continue with the process. We have our success and we have our issues, but at least we try to push for having it continue. We noticed with the snapshot of like 24 patients at that time in Riyadh National Guard Hospital, most of the patients that with COVID-19 were started on ceftriaxone and doxycycline. Azithromycin was in hold and restricted because there was some speculation to have maybe some role in treating COVID-19. But ceftriaxone and doxycycline were given to most of the patients admitted to the ICU. Then later on, later to this medication, piperacillin tazobactam was around 23% actually being used. Then others like meropenins and other medications. We noticed that the appropriateness of our antibiotic were around 87%, and I don't think this is true actually. It was a little bit inflated, maybe because we don't have a close follow-up, and also because it's speculation of the disease itself. Sometimes we're facing a very sick patient, so we think that it's appropriate to start a little bit broader than we go. So we consider that appropriate. I don't have like clear, idea how we can put it, from standard point of view, because this question was before. But generally speaking, we tried our best. I think it's inflated, but it was actually good. So it was not easy, as I said, to assess the appropriateness, and we noticed that some of the physicians in the ICU doctor, whenever they struggle with the patient, they keep changing antibiotic, and we keep arguing with them. But this is what happened. And procalcitonin, as I said before, it was not tested a lot in this 24 patients. 5 patients has respiratory cultures taken among the 24, which is very bad. And when we come to the outcomes, 3 of 24 died and 5 were still hospitalized at that time, and the other were discharged. We did a lot of changes in the system. So we have older system, the BISCARE, which is our electronic patient record. We have a monitoring, factor restrictions. We have a data set that we can go back and see how is people, behavior when prescribed medication. We can reach to the physician himself, or we can look to the area in general and understand how people, behaving in prescribing antibiotics, and we audit them later Also, we did some management toward, number of tests and controlling, abusing the lab and doing a lot of cultures and trying to be just right, because the lab is already overwhelmed with COVID-19, samples. So we put some limitations. Some of the tests were stopped. Some of them were, we couldn't repeat it unless it's 5 days or more. And this was very helpful. A lot of recommendations coming, from everywhere. We try to change every now and then. Just, this week, I changed my recommendation in my hospital towards how to deal with COVID-19 patients. And I think we'll keep this active, and it will be, very dynamic, and we have to keep up and change. Whatever we started early on, it's not now effective. So, or it may be more and exaggerated, so we have to cut it down.
I am Dr. Magid.
Just this is last two slides. So from recommendation point of view, we have to maintain MDRO surveillance. We have to continue education and guidelines. We have to empower stewardship personnel. We have to address behavior factors, peers, involve prescribers, and optimize antimicrobial prescribing in telemedicine, and utilize rapid tests. As a take-home message, as we are going on and continue fighting with COVID-19, we have to continue and maintain our intervention for MDRO spread. And we have to understand first, do no harm. And I think my colleague just mentioned that we shouldn't do anything will harm the patients. One of them giving them antibiotics more than what they need. And we have to understand co-infection, especially in early, non-critical time for outpatient. It's not there, it's not a problem. So we can maintain looking to the patients, observing without giving any antibiotic. As I said, especially non-critical cases with COVID-19 confirmed cases, or those early during their ICU setting. And thank you very much.
Just move to our next presentation. And our next speaker is Dr. Gihad Abdullah. He will be talking to us about certain case studies from the COVID-19 pandemic. What lessons did we learn? Dr. Gihad is a consultant both in internal medicine and infectious diseases, and he is the head of the Infection Control Committee in Al-Rahba Hospital, Abu Dhabi, and he will be talking to us about his case studies. Dr. Gihad.
Thank you very much for the invitation. Good evening to everyone. So our objective today is to go through some cases and discuss and recognize some issues. I don't have a lot of time to present a lot of cases, but I'll try my best. So we're gonna recognize the duration of COVID-19 infectivity, unusual manifestation of COVID-19, how COVID-19 spreads, and why in some cases COVID-19 test by PCR is negative, and we'll discuss some long-term complications. So let's talk first about infectivity. For infectivity, we'll use something called basic reproduction number. And in COVID-19, it's around 3 to 4, which means that one infected person with SARS-CoV-2 can infect up to 3 to 4 people. And honestly, this is not very high compared to, let's say, measles. The number there, the reproduction number is around 15, very high. And you have to bear in mind that you might be contagious when you are still in the incubation period for COVID-19, around 2.5 days before the symptom starts. How the SARS-CoV-2 transmitted, I know many people went through that, many doctors, but let's refresh your memory. 3 ways. The main one is the droplet. So if you have someone sneezing, coughing, or talking loud, and he is 2 meters or less beside you, and he propelled droplets that more in size than 5 micron, it might reach your face, the susceptible host, it might reach your face. I call it the T-zone, eyes, nose, and mouth, and you get infected. The other way is the airborne transmission, which has been recently recognized by CDC. So the same way, if someone coughs, sneezes, or talks loud, and he propels droplets that less than 5 macron, it might fly in the air and stay there for a couple of hours, mainly in very closed, like small closed area, not outdoor areas, and then reaches the same place, the T-zone, the eyes, nose, and mouth, and cause infection. The last way of transmission is what they call it the fomite. So an infected person might sneeze or coughs on his hand and then touches an object, let's say, or sneeze directly to an object and touches the door handle, for example, open the door. Someone else comes later on and opens the door and touches the eyes, nose, or mouth and transmit the virus. And bear in mind the highest infectiousness will take place during the pre-symptomatic and early infection. So let's start with this case. We have a 77-year-old male patient with a past medical history of diabetes and hypertension who was admitted with fever, body ache, and dry cough. He tested positive for COVID-19. He lives at home with his son's family. So the family includes the son, wife, and 3 sons. All of them had no symptoms. He usually isolates himself at home. He doesn't go out, doesn't meet people other than the family members. So the big question, how he acquired COVID-19? And the simple and the straightforward answer, one of the family members who are asymptomatic infected him. So in many studies, there was many studies showing that 6 to 41% of asymptomatic COVID-19 infected people can transmit the disease. On the other studies, pre-symptomatic infection, I told you that patients might be contagious 2.5 days prior to infection, correct? So in one study in Singapore, this was 6.4% infection rate versus in China, one Chinese study, it was up to 44% rate. And this discrepancy might be, I'm not sure, but might be explained by maybe living conditions in China, maybe a larger number of people live in the same apartment. This is one explanation. Also, as I mentioned before, 2.5 days prior to onset of symptoms, you might be contagious. So there was this study that did what they call it hypothetical distribution of SARS-CoV-2 infection viral load. So they have mathematical ways to calculate the viral load using different forms of what they call it distribution curves. And the purple dotted line represents the transmissibility threshold, which is here around 1 million copies of the virus. And in 2 lines, the normal and the Whipple showed that you might be infection 2 days again, at least 2 days before the symptoms for sure. So why it's very important to know who are the asymptomatic infected patients. This is important because it's really difficult to do infection control measures, isolation measures, hand hygiene, contact tracing, when you don't know the source. If the source, the index case, is asymptomatic, sometimes it's really difficult to isolate and do the tracking, the tracing of the contact. Let's go to another case. This is a 67-year-old female with a past medical history of diabetes mellitus, obesity, and hypertension, admitted to the ED with fever and cough for 9 days. In the ED, she developed tachypnea and low oxygen saturation, which did not improve with oxygen supplement. Ended up intubated. They did nasopharyngeal PCR for the SARS-CoV-2, and the results came back negative. And the question, is this COVID-19 infection? And if this is COVID-19 infection, why the PCR test is negative? And the simple answer, yes, most likely this is COVID-19 infection based on the symptoms, and sometimes based on the CT scan and on the inflammatory markers and the labs. But why it's negative, we'll go through that in the next slide. So this is a temporal profile of SARS-CoV-2 viral load And they checked in this study the PCR results from posterior oropharyngeal saliva or deep respiratory samples doing endotracheal aspiration. And this is for, of course, the endotracheal aspiration for intubated patients. And they found the following. In the early days, 10 days and earlier from the beginning of the symptoms, the highest viral load is in the upper respiratory tract, including the oropharyngeal area when you do the PCR testing. And after that, this concentration, the viral load, will go down from the upper respiratory tract and be higher in the lower respiratory tract. And that's why you can't find it in the previous case in the nasopharyngeal swab. This case, or this patient has been having symptoms at least for 9 days. So in that case, if that patient, if they did a BAL, bronchial alveolar lavage, and did deep specimen, test will be most likely positive. Viral load is highest during the first week following symptoms and then diminish slowly. Pneumonia, as I mentioned, might develop late and usually develops after 5 days from the beginning of the symptoms. And usually the upper respiratory tract PCR is negative. So one or more negative results do not rule out the possibility of SARS-CoV-2 infection. Why we have negative tests? Sometimes, as I said, the timing of the specimen is either too early or too late. Sometimes poor specimen quality, or the specimen itself was handled in an appropriate way, or there's some technical problem with the PCR testing. There is inhibition or other problem. So if you have a negative results and you have a PCR negative result obtained from the nasopharyngeal area, and you have high index of suspicion, please do additional sample, and should be, or we prefer to be, deep aspiration, especially if your patient is intubated. This is easy. And this is the temporal consideration for diagnosis. The viral load, the detection of the virus by PCR is usually positive in the first week to 10 days from the onset of the 2 days prior to the onset of the symptoms, up to 10 days after the onset of the symptoms. After that, either deep samples, as I mentioned, the lower respiratory tract, or after 2 weeks, you can detect the antibodies. Antibodies are useless in the first 2 weeks. And this diagram will tell you that the highest viral load is usually early in the disease, when you have progressive stages of the disease. When you are in the recovery stage, the viral load will be down. And when you are cured with minimum symptoms, the likelihood of having positive viral load or viral detection by PCR is minimum. And this is when antibodies can have a role here for diagnosis. And hopefully not too late for this diagnosis. Let's go through another case. This is a 64-year-old male with past medical history of diabetes mellitus, which is poorly controlled. He was admitted to the hospital with fever, body ache, and dry cough. Nasopharyngeal swab for PCR for SARS-CoV-2 is negative twice. Lung CT scan is showing bilateral peripheral ground glass opicities. Is this COVID-19 infection? And should we treat the patient? Based on the symptoms the patient was admitted with, and based on the CT scan findings, this is most likely COVID-19. And as an answer for the second question, I would definitely treat this patient as COVID-19 until proven otherwise. Most of the chest X-ray findings for COVID-19 confirmed cases will show bilateral peripheral ground glass obesities with some consolidation. Usually it's positive between day number 6 and day number 11 post the symptoms onset. And usually in 60 to 90% of the infected patients with COVID-19, the CT scan findings are positive before the initial positive PCR testing. And I remember in Wuhan in China, they ran out of swabs when they have high numbers of patients. And the way they were diagnosing the patients by CT scan. And anyone with consistent symptoms with COVID-19 and abnormal CT scan showing ground glass obesities will treat as COVID-19. Again, in Wuhan, China, they found that the sensitivity of the CT scan imaging, which showing ground glass obesities, mainly peripheral, as you can see in the bottom images, were 97% sensitive and 25% specific using the PCR testing. Like if you have a confirmed case by PCR and you do the CT scan, this is the sensitivity, 97% sensitive in diagnosing COVID-19 infection. Another case, this is a 47 years old female patient diagnosed with COVID-19 pneumonia. She developed urticarial highly pruritic rash over upper and lower extremities 5 days after the diagnosis, the positive PCR and the x-rays and the symptoms. Is this related to COVID-19 infection? And the answer is most likely yes. So let's go back to the basics. The primary symptoms of COVID-19 is mainly fever, number 1 fever, number 2 body ache, and number 3 cough, most likely dry cough, but sometimes you can get headache, you can get nasal congestion, sore throat, muscle ache, and GI symptoms, mainly vomiting and diarrhea. And later on in the disease course, after roughly 7 days, you might develop shortness of breath. And usually the symptoms appear, as I said, after 2 to 14 days post-exposure. And COVID-19 comes with all colors, with all flavors. So either you have a very uncomplicated illness, which is around 90% of infected people, they have any complication, they don't need to go to the hospital, but 20% will do. And those 20% might have mild pneumonia or severe pneumonia or even develop ARDS, sepsis, septic shock, and death. So as I mentioned, it can come with all flavors and all colors. So let's go and check the extrapulmonary manifestations of COVID-19. When you go through dermatology manifestation, you can find a broad spectrum of manifestations, including petechia, urticaria, livido reticalis, vesicles, erythema, or pernio-like lesions. You can have cardiac manifestations from cardiogenic shock to cardiac ischemia or arrhythmia. You can have new onset diabetes mellitus because of pancreas involvement. So someone with no diabetes and comes with COVID symptoms and high sugar, it's because maybe the pancreas is affected. Gastrointestinal, mainly diarrhea and vomiting. Neurological manifestation from stroke to Guillain-Barré or encephalopathy. Thromboembolism, which is the hallmark of the disease. Deep venous thrombosis or pulmonary emboli. Hepatic involvement with high AST/ALT or sometimes obstruction picture with elevated bilirubin. Renal involvement with acute kidney injury, proteinuria, and hematuria. So this article showed what dermatological manifestation associated with mild disease versus moderate disease versus severe disease. So pernio, which is what you see in the digitals and toes, this manifestation is associated with mild disease. Only 16% will be hospitalized. And the arrow goes to the right and changes from green to yellow or even brown, then you will have the moderate manifestation, which is vesicular manifestation, urticaria, erythema, and morbilliform rash, and 22 to 45% will be hospitalized.
2 minutes, doctor.
We have 1 minute. Okay.
2 minutes.
Okay, I have 3 slides. The severe manifestation is what we call the retiform purpura, which indicates that there's emboli, there's a vascular blockage in the dermal and subcutaneous vasculature. And this is associated with severe manifestation. 20% of those patients will be hospitalized and 82% will develop ARDS. The last case I have is a 62 years old female. She has diabetes mellitus and obesity, and she was admitted with fever, cough, and tachypnea, diagnosed with COVID-19 pneumonia, and she was treated, improved. Most of the symptoms, let's say most of the symptoms improved, and she was sent home after her COVID-19 PCR came back negative. She comes to your clinic after 1 month, complaining of persistent weakness, pleuritic chest pain, joint pain, and depression. Is this related to COVID-19? And the answer is most likely yes. But bear in mind that patient with COVID-19 and lung involvement will have ischemic injuries in the lung. And when they did some post-mortem analysis of a patient died of COVID, they found platelets, fibrin, thrombi-rich small blood vessels, indicating ischemia in the lung. And that's why patient might have persistent chest pain and maybe shortness of breath. In this study, Italian study, they followed patients discharged home after having COVID-19 infection. And they saw them in the clinic 2 months after discharge. And guess what? 55% of them had 3 or more persistent symptoms. And what was the big 5s? Fatigue, dyspnea, joint pain, chest pain, and cough. And none of them had fever, which makes you think if anyone comes later on after discharge with recurrent fever, most likely you have to think of something else other than an infection related to the old COVID-19 infection. 44% of those patients reported low quality of life because of COVID, because of the right side signs and symptoms I put there in this study. Thank you very much.
Thank you very much, Dr. Gihad, for this very illustrative presentation and for answering the questions.
Thank you very much, everybody, for being with us at this webinar. It's been a great pleasure for us to have you all attending. And also thank you for the great speakers today. We've been covering many topics regarding to COVID-19, antimicrobial stewardship, and infection control. We also would like to thank our sole sponsor, 3M, for this conference. I would like to remind you about our next virtual conference, which will be on the 30th of October 2020. We'll have more topics, more varied topics about AMR, infection control, and COVID. Thank you all. Thank you, Chairperson.
Thank you very much, Najiba.
Thank you, InfoPlus. Thank you, organizers, InfoPlus. Good night.